Test, test. All right, we will call the West Ada School Board special meeting to order. First item on the agenda is always to do the Pledge of Allegiance, so please stand for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. All right, good evening and welcome. Wanted to just take a minute to welcome some special guests with us tonight. And first just say thank you to all of them for taking a night out of their evenings to join us. So we have Russell Duke from Central District Health here joining us up at the dais. Catherine Turner from the State Epidemiologist and Chief Bureau of Communicable Diseases. She's remote and on the line with us tonight. We have Elke Shaw from the Idaho Division of Public Health, Health and Welfare. She's also remote tonight. Miss Amy White, our attorney from Anderson, Julian Hull, and then Tracy Garner, our Health Services Supervisor, and Jeannie Basheen, our Supervisor of Counseling. So thank you all for coming tonight. Before we turn it over to Derek, I wanted to just cover a couple things. First of all, I think there's been a couple questions around where my vote stands tonight. And so what I did today was ask that Superintendent Bob and Vice Chair Ozuna actually check with the independent third party who is doing the investigation into a complaint filed against me. And the question was, do I have a legal responsibility to recuse myself based on the complaint being filed? And the complaint that was filed. And the response we got was that no, I do not have a legal responsibility to recuse myself. The second question I had for myself was, okay, so now there's no legal requirement. What's the responsibility from a representative of Zone 2? And I'll tell you, I have an inbox full of two different opinions. One is yes, and one is no, I want you to represent me. So tonight I'm going to do what I was asked to do by the zone constituents this entire time, which is represent them. And I will be participating in the discussion and vote. So I wanted to clear that up right at the very beginning so everybody knew that we did do the due diligence to make sure that it was the process that was followed under our policy and our code and the investigation. The second thing I wanted to just kind of clarify tonight or just talk about, and I happened to see a news article before I came in the building tonight that said that this board meeting was about what we were going to do with masks for the rest of the year. And that is actually not accurate. So I want to clarify that right now. I don't think any of us had that discussion. I don't know where that got put out in the public, but that's not what we set this meeting up for tonight. And Dr. Bubb, you sent out the communication, but I think we had the conversation. But the question really before us is, what criteria do we want to look at for when masks required will move to a different status? And so that's why all of these individuals are here tonight, because there are public health experts for the state, for the county, our legal experts, our counseling experts, and our health services experts in our schools. So we've got school operations folks and we've got public health folks. And I think that's really always been the decision with COVID in place or COVID pandemic is how do we manage between all of that? So I want to clarify that we've never been in a situation where we were making a decision for the entire year at this point. So with that, Dr. Bubb, I would turn it over to you.
Madam Chair, Trustees, thank you so much. You're good, Troy. Thank you so much. I want to start, and it'll probably just be a continuation off what you have said. But really, why are we here? And I will just tell you, our school district staff, both at the district office and within our schools, have been inundated with under non-educational purposes. We have now dealt with this pandemic and tried to manage this pandemic for an extended period of time. We want our principals to be instructional leaders. We want our teachers to be building relationships with kids. We believe in all of those items. And we really want to get back to the job of education, what we all signed up for. We have an overwhelming number of resources that are fielding COVID-19 protocols within the district. We're not saying we want to walk away from those, but this is one piece that I think is causing a lot of burnout and that we really need to discuss. We also believe firmly in public transparency and being able to have a really good conversation with our entire board to say, hey, this is where we are all at, and everybody can hear this, whether that be online or in person. This is a complex decision, and when complex decisions are made, it's not one person. I really appreciate all of the people that are here with us tonight who have given up their additional time from CDH, Department of Health and Welfare. I appreciate you guys taking the time to be here and be part of this decision-making process. Where are we going? At some point, we need to get to a mask optional situation where we ask kids to stay at home when they're sick, and we minimize our contact tracing, or we transfer that contact tracing to our local health districts. We need to stay in the business of education, and obviously maintaining a safe environment for our kids is part of education. That's not to walk away from that, but I think there's some protocols we can look at to say when do we get to that next step? Because here's what the truth is. One of our doctors, I just read a doctor from St. Al's said the other day, he said, COVID is probably here to stay for a while. So we need to be able to develop systems, put systems in place that allow us to function without burning out our teachers, our administrators, and our school staff, where we can have some longevity. This is going to be something that we need to be able to function in for a long period of time. What the conversation is tonight is really surrounds this: what indicators do we look at to move in that direction? If we say, hey, at some point we do need to get into that arena, what indicators are we going to look at to move in this direction? That's the input I would really like from our board, to be able to find out where are we today and what indicators are we going to look at as we move forward with this obviously ever-changing pandemic. Some of our data that we have seen, I'll kind of go through the slide that's in front of us right now. We started out with 60 cases. I'll just tell you that it was a 2-day week, 60 cases. So if you prorated that, that's probably going to be right around that 185. The next week, we had 185 cases. The following week, 204. We have seen a slight drop to 188, 166. Last week, or 2 weeks ago, September 27th, we were down to 129, and this last week we were down to 55. Our cases are reported, school-based cases, or school cases, students that were positive within the school setting. I think some critical information to go over. We currently, as of right now, and I say right now, this was as of about 5 o'clock this afternoon, we currently have 64 active cases throughout the district. I did a little bit of research to look at the top 10 in size, the top 10 districts in size around the state to see where they are at. 3 of the top 10 districts within the state currently have a mask requirement. Vaccine for all ages, looks like they will make a decision for vaccine for all, for ages 5 through 11 will be opened up at some point. Looks like the FDA is going to make a decision on that, or make an announcement on that on October 26th when they meet. And Ada County positivity rate currently sits at 13.29%. That's from CDH as of yesterday. I want to again thank Dr. Turner, Russ Duke, Tracy Garner, Jeannie Mouchine, Elke for all being here tonight to be part of this conversation. I think it's really important that we bring everybody to the table, that we have the experts here to sit and talk to us about. This is a public health issue, and we want to know where we're at with that. And I'm sure this is going to be a really positive conversation, but I think it's important to put all our cards on the table, and so everybody knows where the struggles are and where we want to get to. So with that, we can absolutely start a conversation, and I'll turn it back over. Thank you.
Thank you. I think process-wise, what we were going to look to tonight, Dr. Turner can't be with us the whole night, so we were going to let her go first and just process-wise, as long as the board is good with this, I think we get some input from each one of those experts, and then the board can ask some questions, and I think we'll take questions on Dr. Turner before she goes. We did set a time limit. I think we've learned really quite a few times now that no good decision is made after 10 p.m. So we've set a time limit tonight, so I just want to make, for the meeting, doesn't necessarily mean for the decision, but for the meeting, that we would end at 10 p.m. tonight. So just kind of keeping that in mind as we're working through this process. And we'll get some information and then have some questions and then have a board discussion. And we have on our agenda potential action. And I think we would ask the folks that are talking to us to talk from the areas of expertise, and then let us know what information would be important for the board to know as we look to hit those goals of how do we get to a mass optional category, what do we need to be looking at. So with that, Dr. Turner, I think we set you up, we got a reversed order on our special guest, but we put you on the top. I appreciate your time, and the floor is yours.
Well, thank you so much. I just want to do a sound check and make sure you guys can hear me okay.
We can hear you good. Thank you. Wonderful.
Okay. Well, I'm just going to make just a few brief comments, sort of at the, kind of high level, and then I'm happy to answer weedy questions. And I'll stay on after Director Duke provides his comments, and I'm happy to stay on and answer any questions. So jumping right in, no surprise, case count still remains pretty high in Idaho, as does our test percent positivity rate. And we are thankful that the number of people hospitalized with COVID-19 appears to be declining, but those patient counts remain about 30% higher than they were during our peak in early December of last year. So while they are declining, they're still very, very high. Cases among students and staff and teachers do tend to be a reflection of what is happening in the community, which is why those layered prevention strategies for schools are recommended based on the level of community transmission. And those levels are measured by either the rate of cases or the percent positivity in a community, whichever of those is higher. And then as far as defining that transmission level, I'll just do what high community transmission is, and that's if a community's case counts are greater than or equal to 100 cases per 100,000 people over a 7-day period, or that there's a percent positivity, a testing percent positivity of greater than or equal to 10% in the last 7 days. So we know that for some of our public health districts, caseloads are very high, remain, and they're doing their best to keep up with them. But the case reports submitted to the state for our daily dashboard updates are likely deflated because of pending cases that have not been processed. And that is just the reality of where we are right now. And so for that reason, considering the test percent positivity is likely the best measure of virus transmission in Idaho communities right now. As of last Saturday, October 9th, there were 34 Idaho counties that had a percent positivity greater than 10%, which puts 3/4 of Idaho's communities in the high transmission category, including Ada County, with a percent positivity rate of just over 10%. We have tried to look at the cases that have been processed by Central District Health and combine them with what we know about test results that have come in that may not have been processed yet. And a loose estimate is that right now the case counts are probably about 40 cases per 100,000 population below what they should be on our dashboard. Those are some very brief, high-level updates on what we're seeing around the state. I didn't want to get too much into the weeds because I don't do well without visuals. So, but I'm happy to take any questions about anything that I've presented, or if you want to dive into the weeds on any of those.
Thank you, Dr. Turner. Is there any questions from the board? Trustee Kloppenstein.
Thank you very much, Madam Chair. I just wanted to ask a question about the 10%. We had earlier heard about a 5% rate, and I was just curious, what's the difference? It was something that I believe during the early part of the pandemic, they were saying 5% positivity represented community spread. Now you're saying 10%. I just want to understand the difference.
Yeah, it's a great question. Early on in the pandemic, 5% seemed like a really high percent positivity. But as we have learned more about the virus and as testing has increased, if you'll remember, it was very hard to get tested early on in the pandemic. So, the assumption was that if you were even finding 5% of the people you were testing being positive, that was a bad thing. We want it to be below 5%, no doubt about it. That is the goal, is below 5%. High transmission is 10% or above. So when you get down to 5%, at that point you're looking at community transmission, but it's generally considered a lower community transmission, and puts it in that low category. I hope that answered your question.
Yes, thank you very much.
Sure.
Other questions? Trustee Kofelt.
Yeah, Madam Chair, is it okay if I just do a couple follow-on?
Yeah,
okay,
go
thank
ahead.
you. Thank you, Dr. Turner, for being here. A question that I know I'm asked a lot and I struggle with too, from a state, and I'm going to ask the same question to Mr. Duke, but why is it that the state medical public health agencies are still only recommending masks and have not issued any sort of a mandate?
Well, that is a good question, and I think all of you have heard Governor Little indicate that those sorts of decisions need to be made at the local level. Idaho is the 14th largest state in the U.S. for land, and what may be happening in Idaho Falls may be very different than what is happening in, say, Coeur d'Alene. And for that reason, he has indicated that he would prefer that those decisions be made at the local level based on what's going on in local communities.
Okay, thank you. A follow-up question is, we heard from Superintendent Bubb that with his research, 3 out of the 10 largest districts have mask mandates. So 7 out of the largest don't have a mask mandate. We started the school year with a mask optional policy. And, my question is, I believe we had about 30%, correct me if I'm wrong, Dr. Bubb, but about 30% of our students or families opted out of the mask. So just rough math, that's about 14,000 kids, roughly. And so my question is, do you believe that with no mask mandate in our community, no mask mandate other than just in the classroom, nowhere else in the school, none of the extracurricular activities, nothing of this nature, do you believe that masking only our students out of the entire community will really have any impact on the community health status?
So there's a couple of things woven into that question, and the first one is regarding the classroom setting. And it is true that generally speaking, the school classroom is the place where our students are going to be in close quarters to the most people, right? So that's why the masking in classrooms is considered a best practice and is recommended, is because the chances of being in close contact with somebody is much higher in that classroom than when, or on the bus for that matter, than when that child is going home and just being around their family. We can social distance pretty easy in grocery stores and that sort of thing, but that is the reasoning behind that recommendation. There's also been some school districts, North Carolina comes to mind, who have done studies of sort of that case control study of students who are wearing masks in the classroom versus not. So it's the same level of community transmission. The kids are exposed to the same level of community transmission, and the kiddos that were wearing the masks were significantly less likely to turn up positive for the virus that causes COVID-19. So that's not to say that the virus is being transmitted in the classroom per se, but the chance of a kiddo being exposed to more than their household is higher when they are in the school environment. So that's kind of why those recommendations were made. It's level of risk combined with the fact that we do have some evidence from school districts in the U.S. who have done case control studies that it appears that masking does reduce the proportion of students that are going to test positive.
Okay, and just thank you. And my last question is, do you believe that the masking of children has a negative social and emotional impact on them from your experience?
Well, that's a really good question, and I'm going to tell you right now that I am a mom, but I'm a mom of one, so I am not an expert in child development. I am not an expert in education. I am an epidemiologist. So I can't answer that question with any level of expertise. I can talk to you from a public health standpoint, but from a child development, that is not my area of expertise, and I would prefer not to go wading in that area.
I appreciate your candor. Thank you.
And we might be able to get that with Ms. Bouchine, so when we get to her.
Perfect.
Okay, cool. Any other questions?
I'm good.
Trustee Ozuna.
Dr. Turner, thanks for your time tonight. This is Trustee Ozuna. I wanted to ask about crisis standards of care and what, I think you're involved in that decision. So what does it look like to move us out of crisis standards of care?
Well, I really appreciate that question. I think I'm actually going to defer that to our Division of Public Health Administrator, Ms. Elke Shaw-Tulloch. She is on the line and is way closer to the crisis standards of care than I am.
Thank you.
Would you like me to go ahead and
Go ahead.
address that?
Yes, please. Thank you.
Okay, great. Thank you. So hopefully you all have had the chance to listen to our media briefings, and we talk about this quite a bit, about crisis standards of care. I think the director actually put it very succinctly yesterday on our media briefing that, looking at the crisis standards of care, and Dr. Nemerson also was on the media briefing and talked about this, what they feel takes them out of crisis standards of care is when the hospital can offer care as they normally would. That's going to look a little bit different in different locations, but really what takes a healthcare system in and out of crisis standards of care is the level of care that they can provide to the patient at the time and the type of decisions that they need to make. So you're seeing across the state healthcare systems approaching us saying, we can't handle the patients that we have right now and offer the usual standard of care. We're having to make tough decisions with scarce resources. And when they feel that they can move back into a more normal care situation is when they feel they can then, request or move themselves out of that. So it's really kind of an individual healthcare system by system process, an individual patient that's right in front of them, what types of decisions they need to make, what kind of resources they have. And we've heard the hospitals over and over and over again say to us, we would not be operating like this if the volume of COVID patients coming into our hospitals weren't so high. We can't handle the volume of patients that are coming in. We don't have the resources and we can't offer that usual source of care. When the volume decreases, they can go back to that. Then they're telling us they can kind of toggle that back down to at least contingency level of care.
Any follow-up?
No, thank you.
Thank you. Any other questions? Trustee Buffy.
Thank you, Madam Chair. Thank you, Dr. Turner and Administrator Shaw-Tulik. I don't know which would be more appropriate for this question, but I'm just wondering if we could hear a description on what it looks like for a transition from pandemic to endemic, what that would look like.
This is Dr. Turner. I'll take that one. So there's been some comments made in the media as well as locally about we need to learn how to live with COVID, and it's going to become an endemic disease. And I think that it's good for us to think that way because it helps us to plan and prepare for the potential that it does become an endemic virus, such as the influenza virus, for instance. However, I don't believe that we are at a point yet to say that it is definitely going to become endemic. I think it's definitely going to be here for a while. And if it does indeed turn out to be something like the influenza virus where, we have to get an annual, immunization, or we just have to watch for signs and symptoms and stay home when we're sick and that sort of thing like we do during the influenza season. That is definitely a possibility, but I don't feel that we're at a point in public health yet that we are willing to say with certainty that it is going to be an endemic virus.
Thank you. Follow-up?
No, thank you.
Yeah, Trustee Kofelt.
Thank you, Madam Chair. Dr. Turner, just kind of a follow-up. Is the entire state of Idaho operating under the crisis standard of care right now?
Kathy, I can answer that, and it's yes.
Yeah, thanks. That'd be great.
Yeah, the short answer is yes to your question. The entire state is operating under crisis standards of care because we've had multiple hospitals approach us, and including the two major hospitals here in the Treasure Valley, approach us to request crisis standards of care. Given that hospitals share resources, given the level of stress that hospitals are seeing across the state, the Crisis Standards of Care Activation Committee recommended to the director, and he approved and the governor approved entering the entire state in the Crisis Standards of Care. That said, individual hospitals may, I've used the word toggle earlier, but may kind of launch in and out of operating in a crisis, even from an hour-to-hour basis, depending upon the patients that are there in front of them and the types of care that they need. So even though the whole state is technically in crisis standards of care, individual hospitals may be not operating in crisis standards of care while others are. But the whole state, and kind of the major emphasis of being in crisis standards of care, is that we have a problem. And the problem is there are too many patients coming into the hospital and we can't offer care as usual.
Go ahead.
Okay, thank you. Thank you. A quick follow-up to that, and I know my questions are pointed, and so I mean no disrespect. My challenge as a school board trustee is, right now the schools are the only people, some of the schools, that are in a position of doing mask mandates. And so if our entire state is in a crisis standard of care, and Dr. Turner, you mentioned that at least from what you're seeing and the studies and the feedback, that masks make a difference. Why is it that the state is not in a mask mandate then, and only the schools are being asked to do this?
Kathy,
Sorry,
you want me to?
Oh, I'm sorry, Elke. If you want to answer, that's fine. I was having trouble getting off mute.
Sure. And my apologies for the pet noise that's going on behind me. So I really appreciate the comment, and I want to first acknowledge the challenge of it. And none of us in public health are saying that any of this is easy. It's incredibly challenging. And you know, we advise the governor, we advise you know, policymakers at state and local level, and that's, you know, your decisions on what policies you create. So that said, it is a challenge when we're asking local policymakers to make some of those decisions, because it is kind of fickle in the sense that some areas have high community transmission, some have lower. You know, one week they might be in one status, another week they might be in a different status. So I like the comments that were made earlier about the intent of this meeting, that, you know, declaring right now a mask mandate for the entire school year may not be the most prudent thing. And maybe you look at the immediate future and setting up your criteria to say, so this is when we want to change because our community transmission rates have lessened, our hospital stress has lessened, et cetera.
Thank you.
Thank you. Any other questions? I have a couple. And it kind of follows along the line. Oh.
I was just going to say I have a couple.
Okay. Yeah, absolutely. Do you want to go first? Go ahead.
Madam Chair, thank you. Dr. Turner or Elke, my question is around this crisis standards of care, and it's probably a little bit along the lines of what you've already heard. But I have a senior leadership brief from Ada County, and it says the MOCC, which is the Medical Operations Coordination Cell, has organized a statewide notification system to find unique bed available. And I'll paraphrase here, but it says the ultimate objective of the notification system is to prevent any hospitals in the state from having to go to internal triage committees, which I absolutely agree with. At this time, we are accepting patients from District 1, which is the Panhandle. If we're doing that, and I'm not at all saying that we shouldn't be accepting patients. I want everybody to get the hospital care they need. But if we're doing that, am I right in assuming that the Treasure Valley area is probably going to be the last group to get out of crisis standards of care if we're continuing to accept patients from areas that are not masked up? Are you following my train of thought there?
Yeah, this is Kathy. I'll take this one again. This is Elke again. So I understand what you're saying completely, and you know, typically healthcare does have some fluidity to it. I mean, patient transfers happen all the time across the state, regardless of COVID, because certain hospitals have, you know, different levels of care that they can offer than others. So just because, let's say, for example, St. Luke's and St. Alice are taking patients from Kootenai Health or a hospital in North Idaho, you know, they definitely look to their nearest neighbors and the resources that they have closest to them to address the problem. We've helped them set up this statewide system through the Medical Operations Coordination Cell. We have 24/7 support to hospitals to help with patient transfers. The first place they go is their regional healthcare coalition in their regional area to try to solve the problem. If they have, you know, dramatic needs and can't care for those patients locally, then we want to do everything we can to support those hospitals to take care of their patients as best we can. Because even though it might be happening in different pockets around the state, it really truly is all one big healthcare system. So I don't want to speculate that just because Kootenai or Northern Idaho does not have mask mandates in schools, that it will mean that St. Alice and St. Luke's and hospitals in the Treasure Valley can't get out of crisis standards of care. I don't necessarily believe that's the case, but that's more of a question for the hospitals.
Follow up.
Thank you, Madam Chair. Just one more question, and I appreciate that, and I hope that didn't come across as that we're not here to offer care for as many patients as possible. I absolutely understand that. I just have concerns on that, and that's a question that I oftentimes get asked. The other one, and really, Dr. Turner, you mentioned this idea of local control, and you talked about how one area of the state is much different than another area of the state. One of the things that we suggested was maybe looking at this on a school-by-school basis, which is really that local control idea, even on a very, very, very micro level. We feel like our schools are our own micro community, just like Idaho Falls is different than Boise, which is different than Eagle. Can you walk through kind of your thoughts on handling this on a school-by-school basis? At this time, we have several schools that don't have any cases within. Can you walk through what your thoughts are on that?
Yeah, this is Kathy. I hear exactly what you're saying, and you're absolutely right. I think that if it was possible to drill down to a school level, that would be amazing. However, that is exceedingly difficult to figure out that these people are within this school's catchment area versus this school's catchment area, and trying to parse data in that way, mostly because it can be extremely difficult to figure out what the denominator is. So I think that taking into account what is going on in the school on top of what is going on in the community is a great approach, but it would be very difficult to do the data in any standardized way on a regular basis and have numbers that wouldn't swing so far up and down. I mean, in some of our counties, to be perfectly honest with you, the populations are so small that they can move from low transmission to substantial transmission to high over the course of 3 weeks because the data are just going to bounce around because of small numbers. It would be even harder to manage that if you were looking at like a school catchment area. And that's just from a data perspective.
Thank you.
Thank you. I appreciate it.
Dr. Turner and Elke, I have a couple questions. This is Amy. Kind of to follow along the lines, I want to get real clarity on what the public health recommendation is. So, and I want to just take it, because folks have been, and me personally too, have interpreted the recommended language multiple different ways. So are we saying, or are you saying, when you recommend schools do universal masking and you think of West Ada, are you recommending that we actually have a mask requirement in place right now?
This is Kathy. I'll take a stab at it and then turn it over to Elke for her thoughts. It is a recommendation. So universal masking is a policy decision. When we use the word mandate, that to me equates to a law. But universal masking is the recommendation for the reasons that we spoke about. Another compelling reason to encourage universal masking is that if a case does show up in the school, if everybody's got a mask on, there's no quarantine. So that is another compelling reason for people to have masks on, because we can assume that if both people were masked, both the infected person and the other person that may have been their close contact, that they were probably protected enough that they don't need to quarantine, and that keeps kids in school. And really, that is the goal, right? So those are my thoughts on that. I don't know, Elke, if you have anything additional you want to add.
No, Kathy, I think you did great. Thank you.
Thank you. Another question, because this has come up a couple times, is who technically can put a mask? I'm calling it a requirement, but if you want to call it a mandate, that works too. Who technically can put a mask requirement in place, both at a state level, a county level, and then we know at the school board level?
So Elke, do you want to take that one? You might have a better insight into that.
Yeah, sorry, I have dogs barking in the background. My apologies. I can't get to them. I guess, I'm not, again, I'm not a lawyer. We make recommendations to policymakers. And so I would say, certainly you've seen the governor take action early on in the pandemic with our stay-home orders. We know that cities, that mayors can make those policy decisions as well. I'm not so sure about the county commissioners on their level of ability to do that. From my understanding early on, especially with the stay-at-home orders. And Russ Duke, who's on, may have a better, well, I guess he's in there in person, but he may have a better response to this than me. But there are certainly different levels of entities that can make those policy decisions, and you can certainly do that for your local school district on your own.
Thank you. Maybe I'll just be real specific.
And I don't know if I'm really getting to what you're asking.
Yeah, maybe I'll be real specific. As the Idaho Division of Public Health, can you make a public health decision to make masks required in the state?
We do not have because of some legislative action that was taken previously, that impacts the Department of Health and Welfare's authorities. We do not have the ability to do a mandate like that. We make policy recommendations, and it would be up to you to make that policy decision yourself.
Okay, thank you. That helps a lot. Then my last question, and it's probably for Dr. Turner, is, and I think it is, right now the recommendation is for universal masking. What should we use as criteria for getting out of universal masking, in your opinion?
Yeah, that's a great question. Well, I think there's a few things that that policymakers can consider. They can consider the vaccination rate. They can consider community transmission. You know, we do have those transmission levels, and I would just encourage you all to kind of review those transmission levels and what the different layered prevention strategies are at each of those levels. I will tell you that right now, that all of the evidence that we have based on studies that have been done is that universal masking is probably the most effective prevention strategy that can be used. Masks do work. And when you want to consider removing some of those layered prevention strategies, you want to consider what are you going to do in lieu of that. So perhaps you want to have a very robust screening program, you know, to screen staff and students. You know, if our vaccination rates among school-age children were higher, that might be a consideration. You know, if you have a community where you've got very high vaccination rates among your you know, at least the high school students, the middle and high school students, and possibly in the future our elementary school students, you could consider the vaccination rate when making decisions about reducing, you know, kind of letting up on the masking. So those are some things. The prevention strategies are meant to be layered so that there are options. And then, you know, maybe you are doing a screening program. Right now, it's even with masking, schools that do consider using surveillance screening would need to do a random sample of at least 10% of their students. But maybe you decide to do a quarter of your students a week or something like that. And that may be enough for you to consider whether or not you want to continue going with masking. So it's really about those prevention strategies are supposed to be layered. And you can, they recommend if you remove one, do it temporarily, see how things go, and then if things go okay, you can continue on. But it's super important to stay really vigilant if some of those prevention strategies are reduced.
Thank you. Any other questions for Dr. Turney or Elke? I say Elke because I can't pronounce her last name. And I'm, yeah. So,
that's okay.
Trustee Kofelt.
Thank you, Madam Chair. Yeah, a question kind of around alternative mitigation measures. What are your thoughts on if we were in a mask optional policy and we have a student that tests positive, and for those that were exposed but are asymptomatic, if they were to be able to remain at school, but they just had to wear a mask for their quarantine period. You know, my understanding on this is the masks are meant to protect those around you, not necessarily protect you. And so therefore, if that individual went into a mask and they were checked daily and remained asymptomatic but remained at school, hopefully I made that question clear. And what are your thoughts on that as an approach?
Yeah, that's a really compelling question. And what I would say is, as long as the other mitigation strategies are in place, so that student is physically distanced, is wearing their mask properly and all the time, the risk could be fairly low. I would also add on to that they should probably be tested at, day 3, day 5, and day 10 after exposure, just to make sure they're not asymptomatically carrying the virus. And that's what we do when we have a household member that tests positive, is we ask that person to wear a mask when they're around their household members if they can't, physically distance to the point that they can quarantine themselves in the house. So, that is a strategy that could be implemented, and I would probably want to do a little bit of a lit review to see if there's been some studies done to see how effective that is before I endorsed it, so to speak. But I think that could be a policy option to test and see how it works.
Thank you. I actually have that same or similar question along those lines around contact tracing, because I think we heard just what a strain that is on our resources for us to be doing that. And frankly, I think we're doing it because the public health resources are not available to do it. So what are your thoughts on removing contact tracing?
Yeah, so again, if you have universal masking, contact tracing gets a lot easier. I'm just going to say that right up front. So that policy, the masking policy, could be implemented in order to reduce the resources it takes to do contact tracing. If everybody's wearing masks, you don't have to put people in quarantine. So that's one consideration. I would say that if masking is not universal, contact tracing is imperative, because especially with the Delta variant and the transmissibility of it, if you're a close contact to somebody who's infected, you likely were exposed, and there's a good chance that you're going to be infected.
Maybe let me kind of phrase it this way. So for us, how that looks, because I want to talk about kind of how that looks in a school, is in a school there's a student tests positive, mask on or mask off is probably two different scenarios, right? But those kids are in a class together. There's 25 to 30 of them in the class. So in lieu of a massive contact tracing work effort, one of the things that's been suggested is that we just notify the whole class that there's a positive case, and for the parents to watch for symptoms and keep them home in that case. So can you kind of help us? That would ease our burden. That still gets the notification out. I kind of want to walk through that a little bit.
Yeah, I think what I would ask for clarification is, are the kids masked or not?
So give it to me in both scenarios. That would help.
Okay. Well, if all of the kids in the classroom were masked, as well as the teacher, I think that a testing strategy could be implemented. Obviously you want to notify the parents. I mean, no question about that. A testing strategy could be implemented. I think we all know that kids have a tendency to have milder illness, and sometimes they're asymptomatic and may be incubating that virus and be infectious, but not showing any symptoms at all. So in the case that the whole class was masked, you could notify the parents and perhaps have a testing solution to test it, intervals to just make sure no one is asymptomatically infected. And that might work. Now, if the kids aren't masked, that's a whole different scenario, because the last thing you want is you don't want a child who's been exposed to, excuse me, to expose somebody, pardon me, I'm so sorry, to expose somebody outside the classroom. So you run that risk.
Thank you, Dr. Turner. Hopefully you can grab a drink of water. And don't worry if you need to take a pause to do that. There's one other question, and I think this is one that's come up a ton, which is, I think Dr. Bubb said we have 3 districts that are requiring masks of our 10 largest districts. I know we have a number of other districts in the valley here who are not doing any of the items we've just discussed: masking, quarantining, and contact tracing. And what we've seen or heard, I don't know that I've seen the detailed data from, and maybe Mr. Duke can speak to this a little bit, but is that there's not a significant difference between those districts that are masking and doing quarantine procedures and contact tracing and those that aren't. Have you guys looked into that, and what have you seen if you have?
So this is Kathy again. So got a little drink of water. We don't have great data on schools, mostly because it's all aggregated. So we request information from the public health districts, and so what we get at the state level are aggregate numbers of cases and contacts and that sort of thing. When we are investigating, or when we see the data on individual cases, which I think it would be necessary to sort of do that comparison, we don't know that a particular person is associated with a particular school. And so it's a little difficult for us to do really careful comparisons. I do think that at the local level, and Director Duke may have more insight into this, they are looking at that, but it's very difficult when rolled up to the state level to compare one school to another based on their policies and based on, because there's so much that goes into it: community level transmission, the policies in the school regarding physical distancing, masking, testing strategies. All of those things may vary significantly from school to school, so it's hard to do an apples and apples comparison.
Okay, thank you. Any other questions? Oh, Trustee Ozuna.
Thank you, Madam Chair. Dr. Turner, you mentioned testing a few times as a mitigating measure. Are we at a place where there's plenty of tests available to do testing at 3, 5, 10 days for every student that's in this type of a situation?
Yeah, so there's a couple of options for schools right now. Most schools are only doing diagnostic testing, and that seems to be what the demand is for. However, there are a few options for schools to do surveillance testing, either by hiring, a contractor that will come in and do that surveillance testing, and that really does free up resources in the school, so you don't have to have your school nurse totally doing testing all the time. We are also trying to get our hands on more rapid tests. You're all probably aware that it's really hard to find a rapid test around here because the at-home testing supply is substantially decreased in Idaho, mostly because people are buying them because of our case rates and their level of exposure. We have had some schools who have indicated they would like to start a surveillance testing program, but most of the ones that we have talked to are looking at hiring somebody to come in and perform that testing for them. But we're trying to figure out a way where we can get rapid tests into the hands of parents so that schools can maybe give those to parents and facilitate that sort of testing. The vault test does have a 24 to 48-hour turnaround, so it's not as timely, but it is one of the options that is available right now to do serial testing for contacts.
Thank you. Can you walk through, because I don't think we've had anybody talk to us about surveillance testing before. Can you walk through what that looks like?
Yeah, I'm happy to. So surveillance testing is, well, I'll tell you what is sort of commonly seen. What usually happens is a school will test a random sample of at least 10% of students or more, or they'll do testing of higher risk students, like those who participate in athletics, who might have more opportunity for exposure because it's hard to do all of your practice in a mask. It's hard to be in the locker room with a mask, that sort of thing. But usually what happens is 10% of the students at least are tested weekly. And then that kind of gives you a school level percent positivity, essentially. So you can look at that and say, oh, we didn't get any positive hits this week. Okay, so we can assume based on that there isn't any virus transmission going on in our school. If you get a 50% positivity, then the actions would be much different. And there's different testing platforms that can be used. A lot of schools are using the vault test that the state is providing for free. Again, it's a PCR test, so it's very, very sensitive and accurate. But there is a little bit of a delay in getting the results back because the sample has to be shipped. You can do it at home, but it has to be tested by a lab. So it has to be sent. It has to be sent overnighted to the lab, and then they do the testing. So there's a little bit of a delay. For those rapid tests that only take, between 15 minutes and 30 minutes, depending on how good you are at doing all the things you have to do with the test, those are probably a little bit more convenient. They're not as accurate, especially when community transmission is low. But with community transmission at the levels that it currently is, those rapid antigen tests are probably a really good option. And like I said, what we're trying to do is find a way to provide that sort of test to schools, because I think parents have been relying on the over-the-counter test that you can get at a drugstore or, your local Fred Meyer or whatever. And those are kind of hard to find right now. But those can be used, and they're done in the comfort of your own home. For larger districts, though, again, one of the options could be to hire a contractor to come in and perform the surveillance. It's sort of turnkey. They come in, they do the swabbing, they take care of the testing, and they report the results back. And that might be the best option for well-resourced districts or schools. I hope I answered the question.
Yes, thank you. Is there any other questions? All right. Did I hear you, Dr. Turner, say you would stay on the line, or did you say you were going to have to go?
Nope, I can stay on for a little bit longer. I can multitask a little bit.
Yeah, fair enough. All right, we'll move over to Mr. Duke. Is that good? Are you good with that?
I am, yes, thank you. So first of all, I want to thank you for inviting me this evening. I appreciate the opportunity to speak with you. And I also want to thank you for this current Board of Trustees and the trustees that came before you dealing with the pandemic. It's been a really difficult time for you, for sure, for your staff, and none more so difficult than for the parents, guardians, and students of your school district, the largest school district in the state. So thank you so much. And I jotted some notes down with some of the questions, so hopefully I'll kind of try to address those, but of course be glad to answer the questions again or more specifically. The decision points that you're you're faced with, without question, there's always a lot of opposition, and I'm certain a lot of support as well. It's been a long, more than a year and a half, and there's not a clear end in sight. I know there's a lot of people making predictions. They made predictions in March of 2020, and they still make predictions today, but I'm here to tell you no one really knows where this is going to go and where it might end. So I wanted to share one of the fundamental principles of public health, the practice of public health, especially when you're dealing with a communicable disease, and especially so with a highly infectious respiratory disease, is you do need broad community support to implement the tools that we know will work to slow the spread of a respiratory virus. And as everyone in the room, and you are all well aware of at this point, you have distancing, masking, and then for 12 years of age and older at this time, a highly effective vaccine that prevents severe disease. And kind of as this played out, we saw again back in March of 2020, we had our first case actually in Meridian on March 13th. And then subsequent to that, before the end of March, the governor issued stay-at-home orders, and the virus really got knocked down almost immediately. We had relatively few cases, and then as it drags on, people get tired of staying home, obviously, and then ultimately the idea of wearing masks, which came about at a later time, and there's reasons for that occurring. So the concepts are really simple, but as we've learned, they're very difficult to deploy, and certainly difficult to try to do this on a longer term basis. So just wanted to mention the cases. It was, I think Dr. Bubb mentioned that early in the meeting, is we've had an incredibly difficult time keeping up. It's no surprise to anyone. Hiring individuals for any type of work in this valley right now is difficult. We hire staff, they're temporary positions, and as soon as they find permanent employment, maybe higher wages, they leave. So our ability to hire has been difficult. Our ability to retain is also equally as difficult. Case-wise, back in June, I'll tell you, I thought we were out of this. We were having about 20 cases per day. And as summer went on, things were looking really good, I'm sure for you as well, with the start of school coming up. By mid-September, we had over 700 cases per day. So again, just to put this into perspective, it changed dramatically in that window of time. So there's two things I guess I would look at. The question is, so how do we get out of the circumstance we're in? How do we move from a mask required policy to a mask option policy? And I think there's two data points that I would recommend that you use. One of them is a data point that's not highly accurate right now, and that's the number of cases in our community because of all the reasons I just described, and so did Dr. Turner and Administrator Elke-Shaw-Tolick. The second point, which I think is most critical right now, is the hospitalizations. And that data is accurate. That data is reported every single day. It's on CDC's data COVID tracker. And then we, if you go to our website now, starting today, we'll be publishing it on Mondays and Thursdays. So that's the one data point I think I would, if I were in your shoes, I would focus on, because hospitals who have the inability to provide normal levels of care should, in my opinion, be unacceptable to our entire community. Now, how everyone's responding to that, we're watching and seeing how that plays out. As was noted earlier, is this the responsibility of the schools and to implement these policies for your staff, students, and visitors, or is it the broader community responsibility? And I would 100% argue it's our entire community's responsibility, but the schools are certainly in a position to make those policy decisions that will impact at least that sector of the community. So And I'll talk a little bit about the laws that were asked about earlier. So when you think about where we are today, it's the worst situation our hospitals have been in since the start of the pandemic. We could see it coming with both the cases and with the severity. And I think that's what's really critical in my comments about using both case data and hospitalizations, because if this fades and becomes a common cold, which it very well could be, we could have 3,000 cases a week and very few hospitalizations. As far as I'm concerned, it's over for at least a period of time, unless it becomes more infectious. And again, how this will all play out, no one really knows. But that's kind of the hope strategy, is get to the point where we don't have our hospitals over capacity and having to transfer patients and deny important care that needs to be addressed today and have that be delayed a month or 2 months or however long they're impacted. So that's kind of where I'm at as far as what I would recommend. So it's important to also note, I don't think it was mentioned, is the idea of K through 12. You get that. The 12 to 18-year-olds have the lowest immunization rate in the state of all those who could be vaccinated, and anybody under the age of 12 can't be vaccinated. So the vaccine is working at keeping people out of the hospital and keeping people alive if they are hospitalized. So that'll be, as Dr. Bub noted, later this month, hopefully the FDA and the CDC and others will make a decision on that, and it'll be authorized. But until then, you're in a high-risk environment with a lot of people. You look at West Ada school districts, student population alone, you have more students in your schools than 34 of our 44 counties have for their entire county population. So the impact of your decisions is not insignificant when you're deliberating this tonight and into the future. So that's what I would look at. I would look at case rates. You know, how many cases we're seeing on a weekly basis, not daily, because daily it doesn't matter. You know, Sundays there's fewer cases reported, on holidays there's fewer cases reported, but just looking at those 2-week trend lines and really think about where the hospitals are when they're no longer operating in crisis standards of care. So CDC's recommendation is K through 12, mask based on the Delta variant. I do expect that will change for future variants, depending on, again, how transmissible and how severe they are. But for right now, that would be my recommendation to you. And the other alternative is, if you're not going to follow that to the letter of the law, or it's not the law, it's CDC's guidance, then I would really caution you not to lift a mask requirement, especially while the hospitals are still operating in crisis standards of care. More specifically, Elke had shared that crisis standards of care were authorized statewide. Not all hospitals are operating in crisis standards of care, but both St. Alphonsus and St. Luke's have declared they are both operating in crisis standards of care right now. So I'm sure that information will be public. I was going to address the laws and who has the authorities. Would it be okay to do that? So you have the governor, who has the authority, which he exercised early on. That got transferred to public health districts or local boards of health, and then also city mayors. The counties they apparently don't have the authority to implement any types of orders. During the legislative session of 2021, the legislature basically modified the law for orders of restriction, quarantine, isolation for schools and universities. So Central District Health, Board of Health, does not have the authority to do a mask mandate for West Ada or for any other school district or all school districts. That has now become your responsibility in consultation with the public health agencies, which is great. That's what you're doing tonight. As far as, well, why not just implement it district-wide? There's no one unaffected by this right now, right? The business community is affected, our long-term care facilities are affected. And that was also changed by the Idaho legislature. So Central District Health's Board of Health could implement a mask mandate for, and to be clear, it's indoor public places is what we're recommending, and that's per CDC's guidance. The boards of county commissioners must, they don't have the option, they must review that within 7 days and determine whether it will stand or it won't. And I will tell you, in working with our boards of commissioners, at this point in the game, there's no, it's highly unlikely that they would allow that to stand. So essentially it would be an effort, kind of a lost cause, and 4, 5, 6 days later, it would almost certainly be reversed as county commissioners. The other thing I'll say about our board membership, as the public is well aware, has changed. We never had unanimous agreement on anything that we did early on in the pandemic as far as the board membership. And with the changes that have occurred recently, I think it's highly unlikely that you'll ever see an order coming out of CDH for COVID restrictions. Rather, their preference is, as we continue to issue guidance to pretty much our entire community, not just schools, but obviously we're talking about schools this evening. So hopefully I addressed at least some of the questions that have come up, and I'll be glad to answer any questions you have.
Thank you. Trustee Buffy.
Thank you, Madam Chair. Director Duke, thank you for being here tonight. I believe I heard Dr. Turner say that the recommendation is for universal masking in classrooms, and I may have misunderstood, but I just wanted to clarify with you, is CDH's guidance, is it for universal masking indoors or specifically to the classroom?
Madam Chair.
Go ahead.
Trustee, I would, our recommendation would be universal masking indoors whenever it's feasible. Obviously, if students are having lunch, they can't mask, but if they're indoors within the school setting, and they should be masked. Now, you know, you have to be practical here, right? If somebody's sitting in a classroom by themselves indoors, they don't need to have a mask on. The risk is close contact with others. So when you think about a classroom setting, or trying to think what else, but I guess just all indoor settings where you have students maybe in study groups, they should be masked up when they're in a close proximity to others.
Any follow-up?
Maybe not follow-up, but an additional question?
Yeah, go ahead.
Thank you, Madam Chair. Do you have an idea of any changes to the school guidance that could happen as a result of when a safe and effective vaccine is available for children ages 5 to 11?
Madam Chair.
Go ahead.
Trustee, you know, I would expect there will be, I think two things are happening kind of simultaneously. Is the Delta variant, which is the one where the predominant strain we're seeing in Idaho and throughout the United States, it's been more infectious and more severe than the previous variant. So as that starts to decline, in combination with an effective vaccine for 5 to 11-year-olds, which is what we're looking at, I would certainly expect there to be changes on CDC's guidance. I mean, this really came about kind of late in the game as far as you guys preparing for this current school year. And what it was just simply, I think, the transmissibility and the severity of the virus that caused them to change their recommendations.
Follow-up?
And one more new question. Thank you, Madam Chair. Something you said, Director Duke, sparked my interest. You made a comment about the mask recommendation coming later. I was wondering if you would talk to that a little bit more.
Sure, Madam Chair. Trustee, so back in March of 2020, what happened, not just in Idaho, but throughout the United States, is the inventory of medical masks, were sufficient to meet the typical demand within our health systems. We were unprepared for what occurred, which is the hospitals were starting to go through a lot more medical masks, and the concern was that people, which happened, would go out and try to purchase whatever volume of mask they could get. So the highest priority at that time was focused on ensuring our health system had the ability to safely operate and take care of patients. Again, no one knew what that surge would be. And that's the bottom line, is it was a mechanism to protect the health systems, and at that time people were generally more compliant with the other recommendations like stay home, distance, don't go to big events. As that all started to come kind of back into play, masking became a strong recommendation. At that point, our health systems had adequate inventory. They knew they were able to not reuse N95 masks, for example.
Other questions? Trustee Kloppenstein.
Thank you very much, Madam Chair. I did just have one question concerning the rate of tracking. So you said that the average, is that correct? Is a 2-week, a 14-day period where you're tracking infections within so your time frame is a 14-day?
Madam Chair. So, Trustee, there's a lot of different data points out there. My recommendation is, rather than trying to look at like daily cases, oh, we went down today, so it must be. I mean, it's kind of obvious, right? You can look at any of these charts. So I would look at 2-week trends to make determinations. You know, within a 2-week period, if you see a good downward trend, and then again with the hospitalizations that they come out of crisis standards of care, if you don't follow CDC's guidance, I think that would be your best indicator to make that determination of lifting your current masking policy.
I was curious, we switched from a 14-day period to a 10-day period in mid-September, and does that really matter, or it still covers the majority of cases?
Madam Chair. Trustee, I think 10 days would be just fine. 7 days would be fine. I think we're really looking for the trends, and that would be the point I think you're getting at, is just looking for trends, and then the overall transmission. If we have a 10-day or 2-week or 7-day decline, but we're still seeing high transmission, the highest level of transmission, and the hospitals continue to be impacted, I would wait. I would wait until we get to for the Delta variant, I'd wait till we get to moderate levels of community transmission.
Excellent.
And that's published on CDC's COVID data tracker website by Ada County. You can see that.
Excellent, thank you.
Sure.
Trustee Kofelt.
Thank you, Madam Chair. Yeah, thank you, Mr. Duke, for being here tonight and lending your expertise for us. I'm going to ask you a couple of the questions that I asked Dr. Turner also, and you covered some of them in your opening statement, so I won't repeat those. You know, there's a real concern from not only these trustees, but also from parents. You know, and I'd love to know if you feel comfortable answering. Do you believe there is a negative social or emotional impact to children based on your experience being masked?
Madam Chair, Trustee, actually, Dr. Bubb had asked me to invite one of our medical colleagues who are more familiar with this. You know, we see a lot of patients at our own clinics, and we have mental health services for children, and I can't answer that with any degree of certainty, but as I offered, if a future board meeting, I would certainly be able to line somebody up to join you to talk through that.
Okay. Well,
Yeah, go ahead.
thank you. I thought that might be your answer, but I wanted to give you the shot at it too, so thank you. The same question I posed to Dr. Turner also, as an alternative, and your thoughts on it for how we deal with exposure. So if we were in a mask optional situation and we had one of our students test positive, and a child was not masked, that is considered an exposure. Rather than having them isolate and quarantine at home, if they then had to wear a mask for the 10-day quarantine and be monitored, checked each day, would that be okay to then allow them to remain at school?
Madam Chair, Trustee, I think that would be a reasonable step to accomplish the goal of keeping kids in school. What I would also recommend on top of that, which I think Dr. Turner had mentioned, is periodic testing because of the likelihood of children being asymptomatic but able to spread the disease. So I wouldn't give you a definitive answer tonight and say absolutely, but it's, now that you raised the question, it's something I think we need to seriously consider, because the bottom line is if we're having the same conversation 2 years from now, we got a problem. So we have to figure this out. We have to figure out how to keep kids in the classroom and keep them as not risk-free. That won't happen, but minimize the risk, not only to them, but their families and grandparents and the rest of the community.
Yeah. One last one? Okay, thank you. And I don't want to put words into your mouth, so as I've listened to different doctors outside of tonight's meeting and speak, there seems to be an indication that there might be more of a comfort with moving to a mask optional policy once a vaccine is approved for the remainder of the school-age kids, 5 to 12, and there's been time for them to be adequately vaccinated. Would that be a fair statement?
Madam Chair, Trustee, I would have a lot more comfort with the mask optional policy if we had, and I'll just throw out a number, it's not, this is the target, so don't take it as that, but if we had 70% of our students 5 to 11 vaccinated, yeah, I'd feel a lot more comfortable. If the vaccination rate is 20%, simply because we have the vaccine, but there's no uptake, the risk is just about the same, except for those few that are vaccinated.
One last, I'm sorry. Thank you. A follow-up kind of on that same line is, you know, right now what I kind of heard is, you know, in its general statement, the COVID virus is not hitting children as hard. We don't have the hospitalizations, the deaths, the things that we're having with the adult population. And one of the rationale for masking the children is so that they don't take it home to a more vulnerable population or an adult population. And I guess my concern is, as we kind of push these decisions down the road, is if we get a vaccine approved for kids 5 to 12, and I'll just pull a number at October 26th, when they're going to hear if they approve it, based on the percentage of kids that have received the vaccine in the state, I think it's safe to say we're not going to have many of those kids take the vaccine. Based on the percentage of adults in this state that are vaccinated, I think it's safe to say those parents are probably not going to vaccinate their kids. So waiting for the vaccine, I'm not sure what that does for us, because it's really not going to change any actions of the adults who could be vaccinated now and are choosing not to. So, I mean, that's maybe more of a statement than a question, but I'd love to know your thoughts on it.
Madam Chair and Trustee, I agree 100% with you. I think that the vaccine, if we were waiting to make a decision based on the vaccine being authorized, to me that's misguided. There's no basis for it for all the reasons you mentioned.
Thank you.
Any other questions? I have a couple. Russ, walk me through why, because you gave us two factors, the number of cases in the community and hospitalizations to look at for masking. Why wouldn't our community vaccination rate be one you would recommend? Not school vaccination rates, community vaccination rate.
Madam Chair, I guess when you have a low vaccination rate overall. We've kind of watched how that played out, and I'm sure you're aware of nationally, states with much higher vaccination rates tended to have fewer cases, less impact on their health systems. So in Idaho, where our overall vaccination rate among our entire population is less than 50%, among those who can be vaccinated is a little more than 50%, it's not been effective. When I say it's not been effective, it absolutely has been effective for the individuals who are vaccinated. You hear the hospitals say it over and over again. Their ICU beds are filled with mostly non-vaccinated people. Their hospital COVID census outside of ICU is mostly among non-vaccinated people. So making policy decisions based on vaccine rate, again, it doesn't make sense to me. What makes sense to me is what we're actually seeing. I mean, we could have 90% of our communities vaccinated and our hospitals are triaging people and turning people away. And you'd say, well, we have really good vaccination rates, so we don't need to do anything about it. You know, I think what we see kind of on the ground, what the impact is, which is very apparent right now today in Ada County, is that we're seeing too many people showing up at the hospital with COVID, and it's really stressing them, and it's created a huge burden on our health system in particular. And that's back to my initial comment: is public health is not based on the foundation of everybody for themselves. It's based on the idea of community effort and coordination, and that's why masking, distancing, and of course getting vaccinated are and stay home when you're sick are the four biggest things that we can do right now to get us through this wave. I think that's the key point: is this isn't going to last forever. Based on what we're seeing, it's very encouraging, and I would be hopeful within the next few weeks that decline would remain. It's what you see in other countries, and it's what you see in other states.
Okay, thank you. Just because I have the figure in my head, but I want to make sure it's right. What is our vaccination rate for those that can be vaccinated in Ada County?
Madam Chair, it's a little over 60%.
Which is higher than the state average, correct?
Ada County is the second highest vaccination rate of any county in the state of Idaho, right behind Blaine County.
Okay, thank you. Thank you. I have another, I kind of along those lines, because here's the challenge I see. You just said something that I think, I wholeheartedly understand and think is about public health, which it is public health is about a community health, right? It's not about an individual health. The challenge is the laws I just heard you describe actually take away your ability to do public health management. The way our Idaho laws are set up right now, it takes away your ability to do that. It actually puts it in the hands of the county commissioners to make that final decision based on the public health boards. And then we have that ability to do public health management by the laws in the school district. Do I understand that right?
Madam Chair, you're exactly correct.
Okay, so then our method of management from a state legislature and state policymaker level isn't set up to manage public health the way we need to manage this pandemic.
Madam Chair, it is not how it was. Obviously, the public health district boards of health had the authority, and that change was recently made by the 2021 Idaho legislature.
Okay. So then, here's where the decision point, then I can see now why I guess I didn't realize that law changed, so that was news to me, but here's where the decision point then comes into schools, right? Is we have one responsibility around that, but we have 16 other responsibilities around education. And and when I hear the question that Trustee Gofelt asked around, I guess my question is when do we stop being responsible? And maybe it's not even a question for you, so I apologize. When do we stop having to be responsible for community health decisions? And I ask that question kind of in this: when a parent has access to a vaccine, I know that's not the perfect rate from a community health standpoint, But from a school safety standpoint, we now have, parents have a choice around the protection of their own child, right? And so that's where I kind of, I guess I'm hearing you answer from a community health, but I wanted to kind of see where your thoughts were, because we have that different sort of school health and public, from the school standpoint, school management.
Madam Chair, I guess, you know, the reality with vaccines, I guess I'll start there, is they're not 100% effective. These vaccines are not 100% effective. People in our community of all ages, including the children that are in your classrooms and your teachers and your bus drivers and others, people who are fully vaccinated have died of COVID. Again, it's a much smaller percent than those who are unvaccinated, so that makes it a little bit more complex. I wish it were as simple as get the shot, wait 2 weeks, you're good to go, but it doesn't. No vaccines work that way. So the COVID vaccine is highly effective, but it still leaves people vulnerable, and especially people who are high risk to begin with, which again is not reserved for those who are 90+ years old in a long-term care facility. It's all ages.
Here's where my mind's going. So a community vaccination rate of 60%. Oh, sorry.
Madam Chair, I just want to make sure we get that data right. CDH is reporting at 69% right now.
Oh, okay.
Which, I mean.
Okay. Okay. So there we go. Thank you. That's good. I appreciate it. That's even better. I like that good news. Yeah. So I think about that community vaccination rate and parents having access. I'm not even saying have to. I'm just saying access. To me, that says we have a public health, a high rate of vaccination in the county we mostly operate in. I think we have a really small, like, corner of Canyon County. But we have a pretty high vaccination rate among our population where our kids would go home. And then if the parents have access to also then protect, if they choose, protect their own kids, I guess I'm struggling with why we would continue down the path of, and please don't get me wrong, I appreciate the challenge the hospitals are in so much. I appreciate the challenge that the community's in so much, but I'm struggling with why it's all on the backs of the public schools. And so, and I'm kind of trying to get us out of the middle of the community health piece. And I guess what I'm looking for is your thoughts from a kind of maybe not totally take off your public health district hat, but help us from a, how do we get us out of that public health central point, if we can keep that community vaccination rate high and then also give our parents access, or there's an access point for our parents.
That's a great question, Madam Chair. So I think, you know, when you look at the data, and thanks, Dr. Bubb, for clarifying that, I guess you think about the 12 to 100+ year olds are at 69%. That's of those who are eligible for the vaccine. If you take the entire population, including birth through 11, plus everyone who has access to vaccine, that lowers that rate, and I think it's closer to 60%. If you take just the school population, and you take and I wish I had to, I don't want to cite any data, but it's not, let's say it's 25 or 30% for the 12 to 18-year-olds and 0% for the 5 to 11-year-olds. The population that you're serving, the population you're responsible to educate and keep safe, in doing that, the vaccination rate is the lowest in the state, unless you take daycare.
And I hear all that. I'll tell you why I get comfortable with it is because if the parents are vaccinated, our concern, or what we've been told, is it's when the kids go home and they pass it at home. Well, if we have a high vaccination rate at home and we have access to it, then I guess I'm sort of seeing it like it really now is the community health concern, not the school concern. So that's just my comment. You don't have to respond to that.
Well, Madam Chair, I don't mind. I think, you know, from where I sit, as I noted earlier, you count your staff in the picture, and everybody that's associated with schools and parent interactions and volunteers. I don't know exactly what that number is, but it's even more, a much larger population than more than 34 counties you guys are responsible for. So I hear what you're saying, and I guess my encouragement to you, or if I were talking to Idaho Power or Home Depot, I would recommend masking, universal masking in those indoor public places. So that's what I'm recommending to you. You are responsible for making that decision per the changes to Idaho code. And as I noted, the impact that you can have with that decision right now, not a month from now, certainly not to school year, could be significant for Ada County and what we're seeing. Not necessarily with the kids, but the broader impact that they would have on the community.
I appreciate that. I appreciate your honesty a lot. Thank you. Any other questions?
Madam Chair.
Sorry. You should have said, you should have before me. I always try and go.
No,
last.
you're.
Go ahead.
First of all, thanks for being here, and I really appreciate you communicating with us and being a good colleague, so I appreciate that. I want to walk through, and this is going to be a little bit pointed, and I don't mean it to be, but I'm struggling with this piece, and this is where I struggle answering to our community on this as well. You guys, as you said, you could implement a mask mandate, CDH, but the board would have to approve it within 7 days. Is that accurate?
Madam Chair, public health districts, our Board of Health cannot issue a mask mandate for a public school district, period. If we did a universal, like everybody in Ada County must wear a mask indoors, the way I would interpret the law, not an attorney, that wouldn't apply to school districts because we're prohibited from implementing any types of restrictions for school districts. So broader community mask mandate, not applying to schools, must go through the Board of County Commissioners for their decision whether or not to leave that in place or remove it within 7 days.
Perfect. Okay, so let's go with in public places. At this time, Central District Health has chosen not to go down that road because you felt like your board of directors, or not you, but you as a collective, you, CDH felt like the board of directors would not approve that.
Madam Chair, so I would never be the one to make that decision. It would be the Board of Health. Board members are appointed by county commissioners. So if they chose to implement a mask mandate, then they would be accountable to the county where that was implemented, or if it were district-wide. So I guess, I've not had the conversation with the current board membership about issuing a mask mandate for all indoor public places. I've had conversations with individual board members, and I don't believe there's any interest to do that, and there's a strong belief that the counties would likely overturn such a mandate anyway.
Perfect. Okay, so keep going down this road with me for a second. You guys oversee, Central District Health oversees Ada County, Boise County, Elmore County, and Valley County.
Correct.
You guys have the opportunity to implement that mask mandate. It's an opportunity. Do you have, are there medical professionals on your board?
Madam Chair, Dr. Bubb, we have 3 medical professionals. We have recently appointed dermopathologist, Dr. Cole. We have a retired registered nurse who's the chair of our board, Betty Ann Nettleton, and then a private practice family nurse practitioner, Dr. Jane Young.
Okay, so 3 medical professionals have said it's not worth doing a mask mandate at this time, but instead we're going to say schools. I know people call me Dr. Bubb. Education, that's my expertise. Instead, we're going to have schools. We're recommending schools. If you guys can do this with 0 medical background, can you guys do this? Walk me through that thought process.
Madam Chair, Dr. Bubb, as I noted earlier, our recommendation for indoor masking applies to all indoor public places, not just schools. So I would say that to you to this board, to CUNA School District, to Mountain Home School District, and I would also say the same thing for a public library, for example. I think masks should be worn right now with the current situation we're in, with the cases and the impact of the hospitals and the Delta variant, for all indoor public places.
Understood. So would you be comfortable if we recommended masks to our kids in indoor places?
Madam Chair, as far as my comfort level, I would prefer, however you get there, that your students, your staff, your volunteers, anybody in an indoor public place in the schools would wear a mask. I'm not in a position to make that policy decision, and neither is the Board of Health that I work for.
I appreciate that. And I want to just clarify, I'm not trying to be really pointed with you. My frustration is that we are, again, this is on schools, this is on the backs of kids, to be the protectors of the community.
Thank you. Well, so here's, before we go to the, let me ask this. Is there any other questions of Mr. Duke? Okay, thank you. I'm sure that wasn't fun, so thank you.
Thank you.
So I put a little timer on my phone here for 9 o'clock, but I'm thinking maybe we go 9:15. We got about a half hour, and then give some board discussion time between 9:15 and 10. Is everybody good with that? Is it good? Okay. So I'm assuming, Ms. White, you don't need to give us any, okay, perfect. Thank you. And then since you guys both work for the school district, maybe you guys can tag team together and take the next half hour, and we'll go through the questions from a health and a counseling standpoint. And maybe Ms. Bouchine, because we've had a number of questions around counseling, you can start us off.
Okay. Madam Chair, members of the board, Dr. Bubb, I don't know if, Troy, you can show the slide for me. Dr. Bubb came to me and asked, how are we doing with mental health? And I just thought I'd pull some statistics for you, just a 4-year comparison, because I honestly didn't know. I hadn't looked at these before he asked me the question, where are we at? And so in regards to suicide prevention reports, so that's every time a child, no matter how old, I mean, we're talking about kindergarten through 12th grade, shows any signs of suicide ideology. They could be saying something, they could be writing something, they could be acting, sad or depressed, they could be texting a friend, any of those things. We follow up and we make a phone call home. And that report then gets sent to my office, and we count the statistics. So you can see how many we had all the way from 2017 through the current school year on there. It shows elementary, middle, and high school students broken down, and the total. I thought it was interesting also to compare, the student enrollment and the percentage of that. And I'm not like a current student of statistics, but I can tell you as a former math teacher, that's not statistically anything that we need to worry about. And then on the bottom rung, you can see how right now we've had 154 reports. And we're about a quarter of the way through school, in another few days we will be. So I multiplied that by 4 and did a percentage, and again, we'd be about where we would normally be. So that's just one data point, and that's just one data point for here. I think the question is, do masks cause mental illness? And I think if anybody in this room were to do a little Google search on their phone, they would get the article that aligns with their political belief. And so I don't really want to go down that road with you, but I can tell you that we have kids that don't want to wear a mask, and we have kids that are fine with it. In fact, we have some kids that would prefer to keep wearing them forever, for all sorts of different reasons, just like we all have different ideas and thoughts about that. And we do know that children are resilient, and they are also mirrors of us as adults. They mirror, like if we have a family that's under considerable amount of stress, let's say they have a death in the family, or they have a person that is physically impacted by COVID or whatever, they're going to bring some of that stress to school. I mean, that is just who they are. Little mirrors is what I want you to think about them as being. So if there's a heightened level of stress in the community, we're going to see it in our kids. That's just the reality. And, you know, we need to be, as the adults, the model of self-regulation and positivity. We need to listen and talk and communicate with our kids and be there for our kids, provide that calm, predictable environment. I think the biggest thing for the school counseling department and the social work department is we need kids to be in school. We know that when we were not in school full time, there is probably nobody in the community that thinks that was good for kids. That isolation and that lack of socialization was really tough on most kids. So I don't know if masks are I can't speak to this. I can't say that this is going to cause mental illness. What we do know about mental illness is there's lots of factors, and it's typically trauma, substance abuse, you know, that kind of stuff, background of family, genetics. We're not talking about something that you put on your face that causes mental illness. So I can't speak to that, but again, you know, there's all sorts of stuff that is out there, and you could probably find reasonable articles from reasonable people that seem to be experts that would say on either side of it, of that argument, yes or no, whatever you want to find. So I stand for any questions that you have.
Thank you. Are there any questions from the board? Trustee Kofelt.
I'll really make more of a comment. I appreciate your candor in your answer, because you're exactly right, and I know for me, I struggle with this, and I'll assume my colleagues do, is you're absolutely right. As you're trying to research this information and make an informed decision, you can find something to support your point of view everywhere, and that is what the challenge has been for me. And then it's compounded when our public health agencies and things who have been stripped of their ability, which is news to me, I did not know that until this evening, to help.
Kind of scary, but that's another whole side issue. So, so I think we are actually seeing an increase of parents' awareness, of willingness to go get help, of a decrease of stigma.
Thank you. Any other questions or thoughts? All right, Ms. Garner.
Madam Chair, Board of Trustees, thank you for having me today. I really appreciate being here and the opportunity to talk. Here at West Ada, encountering the pandemic for the last year and a half, we've learned a lot. And it's nice to be able to share those thoughts and what we see versus having those around sometimes tell us what they think is happening in schools or what they see is happening in schools. So thank you for having me here today. I'll talk a little bit about some data points, some clarification of some information I've heard, some data points that were discussed earlier and where West Ada falls within that. And then I'll talk specifically to masks, quarantines, a little bit about testing, and then contact tracing with some recommendations. First, to talk, West Ada has done an amazing job starting last year, October, November. We implemented a leadership dashboard which collects data from a multiple set of data points. With that, Trustee, you asked about, and Mr. Duke talked about trends, 10-day trends, 14-day trends, 30-day trends. That dashboard includes that information. So I invite you to look at that. It's updated as we get cases, so you can look at those 10, 14, and 30-day trends and see what's happening at West Ada. You can break that information down by school. You can look at it by level. You can look at it by geographic area. or you can look at it as the district as a whole. So there's a multitude of ways to look at the data and compare the data. So you could look and see, is there something happening in a geographic area? Do we have something happening in Eagle, Idaho? And seeing it across multiple schools with multiple families. So we felt that if we instituted and implemented a very robust, comprehensive set of data, that we could monitor and create a safety net for while this pandemic goes on. We can watch and see what's happening. So some key points. One thing I wanted to clarify is about the definition of an exposure when it comes to contact tracing for consideration. We understand, and correct me, Mr. Duke, if I'm inaccurate, but the definition of an exposure is a close contact to a positive case by time and distance. It's irregardless of whether there's a mask on or not. Is that correct?
Mr. Duke?
Madam Chair, that is correct. It would be how you handle that
Correct.
in terms of quarantine
Quarantining.
based on masking, so time and distance.
Yes. So I just wanted to point that out. So when we talk about masks and the relevance of masks, and we talk about contact tracing being easier if we wore masks, it actually is the end result of who we quarantine. The contact tracing process still remains the same and still has the same time element. So I wanted to make sure that there was that clarification. So with that, and part of the importance or relevance of that is that here at West Ada, we feel that it's important to track positive infectious cases while at school. If they're not infectious at school, they're not impacting the school environment. An example of that would be a student's at home, they're quarantining because they have a parent that's positive, and they convert to positive, yet they were never in the school environment. We don't count that case at that school because they were never infectious at school. There was no viral load at that school. And so that's one of the items. So we look at positive infectious at school, and then we look at those close contacts, and we split them into two groups. So they're exposures, and those exposures are in two groups. Who needs to isolate because they weren't wearing a mask or weren't wearing it effectively, and then who's gonna quarantine or not have to quarantine and come to school because they were wearing the mask effectively. Of those two groups, then we watch them and monitor them for 14 days to see who converts to positive. Our rate has consistently, for over a year and a half since we've been collecting data, has remained between 0.5% and 1.5% of our exposures converting to positive. So that's the data point that I think is extremely important when we look at making decisions. Is it's a very low risk. We've identified through CDH and through the studies that they do that our risks are our higher risks are community exposures and household exposures. They're a much higher risk than a school exposure. So when we make decisions about masks, quarantining, contact tracing, I think we have to take those decisions in consideration of what's the rate of the exposure. So the other element that came up was testing, and we talked about positivity rates and testing positivity rates. And I believe Dr. Turner said that currently the environment, 13.9% positivity rate, and in excess of 10% is our testing positivity rate. Correct me if I misspoke. Here at West Ada, we started doing testing 3 weeks ago, and we're testing specifically for those school-based exposures and students who are symptomatic but without a known exposure. We chose not to opt and do the surveillance testing, which is testing of otherwise healthy students, because our local health experts asked us, health leaders, to not do that because right now our testing capacity was overwhelmed. So we looked at what's our highest risk. We want to know of our school-based exposures that are quarantining for 10 days, Can we get them back to school safer, that 1.5%? Can we get them back faster than that 10 days and get them back safely? So we started doing testing on that group, so our school-based exposures. And then the other is our symptomatic kids without a known exposure. That's a really questionable in an area of high communicable transmission. But we also are dealing with kids right now with allergy season. And so we wanted to test and see what's happening. So of that testing, we've done over 467 tests. 28 kids have tested positive with a testing positivity rate of 6 to 9.5%. So we're below that 10% that Dr. Turner mentioned earlier as a level of consideration for whether the masks get removed or not. We talked about having a company come in. Previously, it was discussed. In partnership, we do have a local company that's come in and has agreed to do that testing for school-based exposures and for symptoms. We talked about vault testing as an option. It's a reliable PCR test. What we've found with that is we do get results in 24 to 48 hours. It is easy to get to people or to get to testing. They go to national labs, so you're not overwhelming local lab systems. The challenge we've found with the vault testing is that you have to spit in a vial, and it's really hard to get kids to spit that much to fill the vial. And so nice option for our, maybe adolescent students or our adults, but it's a very hard option for children. So couple items then with regards to masks. You heard a lot of conversation about multi-layer infection prevention measures. I want to assure you that West Ada has taken deliberate, intentional steps to ensure that we have multi-layer infection prevention measures in place, focusing on staying home if you have symptoms. We looked at what can we control in our environment. There's talks about vaccinations as well. We can encourage that, but we looked at what is within our control. And a lot of that is stay home if you have symptoms, maximize the distancing to the best of your abilities, increase our hand washing, increase access to hand washing. We increased our cleaning and disinfecting in highly touched areas. A lot of respiratory etiquette, and those infection prevention measures that we've implemented will carry us throughout. It's not something that we're going to stop doing. So I think it is a very robust, multi-layered infection prevention measures that we put in place. So contact tracing, we talked about that. And then the one question that I just asked, I struggle with regards to masks. There's a couple compelling arguments, a couple struggles. I struggle with children. We talked about children in a structured environment with 25 to 35 kids being a high-risk environment, and the importance of those kids in that group of 25 to 35 wearing a mask. Those children are known to not be big spreaders, but we have adults in our community, and we talked about mirroring, who are big spreaders, who, whether vaccinated or not, are in close proximity, thousands in concerts, fairs, and sporting events. So I guess there's a struggle with kids in small groups wearing masks in those groups, and it having a large impact on spreading in the environment. But there's a lot of other activities that are going on that aren't being addressed. And so I get your struggle and I get your challenge. Another compelling argument, I think, or a data set that we could look at is other school districts in our area, in and outside of the state. and whether they're seeing appreciable differences in their illness or absent rates with regards to when they're wearing masks and not. We did talk about predictions with the masks, and I think most of you were here, so I don't need to go through about the past. With quarantines, one of the considerations is with school-based exposures and the percentage of kids that are converting to positive being so low, the current quarantine is 10 days. We've implemented a test on day 4 after 72 hours and return. I would be interested with Mr. Duke if we could go at testing even, with the mask, wearing a mask, and then returning with that negative test on day 3. So I think that's a viable option for us to look at. And then symptoms without known exposures, we've been doing some testing with that, and we're seeing a higher rate of positivity, but still the majority of our kids are coming back to school. So I think that's the testing in those 2 areas remains a good option. Contact tracing, if we were looking at whether we continue to do contact tracing, I think an alternative would be monitoring absence and illness rates, which is what we've done previously before COVID. We look at overall absence and illness rates and monitor those. And we have that tool and that data set within the leadership dashboard that we could continue to monitor. So, any questions?
Thank you. Is there any questions from the board? Trustee Kloppenstein.
Thank you very much, Madam Chair. I was curious, the leadership dashboard is not the COVID-19 dashboard that the public sees, is that correct?
Yes, you're correct.
So is it possible to make that available? Is there a possibility that the trend line after the change in September is slightly different than what was before?
The trend lines, I would have to talk to our data analytics, but the trend lines, if you wanted to add that to the dashboard, I don't see why it couldn't, but it could take some time.
I guess it gets back to, looking at data from the public standpoint and the apples oranges standpoint. And so I'm just curious, because I do see that, week 3, the numbers seem to still be creeping up, and that's beyond a 10-day. Is that, the numbers are being attributed after 10 days, is that correct?
I'm not sure I understand the question.
So in other words, you've got 10 days from, 10 days in the past, right?
Right.
But yet, we're still collecting data back to day 14. So in other words, that dashboard at the COVID-19 site is still ticking up infections that have been reported and have been collected, because kids come back to school, they report. And so from day 10 to 14, we're still collecting numbers, is that correct?
Absolutely, yeah. And I think maybe a better way of looking at that is you can look, so if you wanted to look at 14 or 30-day trending data, you could look at the by week data and follow that, because then you have a 5-week cycle.
Yeah, I just go back to those big box numbers. Again, it just looks like there's a difference in the data, and it just is a concern. From a public standpoint, I like to see apples to apples you can compare over the past. Anyway, just a point. You also said that...
Do you know how you can see the 5 weeks?
I understand how you see the 5 weeks. I see the big boxes that most people would focus on, and they see the potential lowering of those boxes just because we're looking at 10 days over 14. And so to me, it looks like it's a potential of a difference in how the data is interpreted. That's all. I don't want to make a big deal out of it. I just didn't see on what you were talking about that was publicly available.
Got it.
Okay. So the other question I had, if it's okay, Madam Chair, was that you said that there was a potential issue with having enough staff to do testing. Is that correct? Did I hear that right?
I did not say that.
You said that you couldn't do surveillance testing because the testing capacity, you just don't have the people to do it.
Oh, that wasn't our testing capacity. The local health leaders had recommended that that if we did testing, that we did it specific to exposures or symptoms, that to test asymptomatic people periodically in our current environment where it was hard to get tests. I think Dr. Turner had mentioned that a lot of people were having difficulty getting tests, and also the labs were having difficulty getting tests in a timely manner. They were recommending that we don't do the surveillance testing because it would further over impact those lab testing capabilities.
Okay.
But we are doing testing, but just in specific groups.
And if I can just expand on that, in terms of resources, do you need more resources? Are you having issues? Because it's been going on for, what, 19 months now? Has this been challenging for your department?
This is challenging, but leadership continues, as they have from day one, to work with us and come up with solutions to assist staff to help prevent burnout and to, support and increase staff morale. So leadership has been extremely supportive, and I appreciate you asking the question and offering assistance. But I think we're good. I think leadership is very responsive to requests that we've had and that we've made. So thank you. Yeah.
Thank you. Appreciate that.
Any other questions? Trustee Ozuna.
I want to do a follow-up to what Trustee Kloffenstein was asking there. Related to the staff, I've heard that things are very difficult, that the volume of contact tracing is really high, and the calls to parents don't always go the way that we would hope that they would, and that things are tough. Can you talk a little bit about how that looks, maybe for the nursing staff and others that are doing contact tracing? And then, Dr. Bubb, I don't know if you can talk about the impact that this has on our teachers and building administrators.
Yeah, absolutely. And again, thanks for asking. I'll start by saying we have an amazing health services staff. Our nurses, health techs, LPNs have been extremely amazing. They've been up for the challenge. With that being said, yes, it's very difficult. This is all new for us. I think they've taken on the task of contact tracing very deliberately, and they do an amazing job. They are tired. It is a lot of work. We tend to see cases hit schools. We kind of call it in weeks of threes. Weeks of 2 or 3s, you'll see maybe some numbers, you'll see the numbers go up. We've been adding and supplementing staff when that happens. We kind of have a system set up with an SOS, so if they need help, they call out, and somebody who maybe isn't doing contact tracing can help from another building or another site, make some of those calls. I think if we talked about the biggest challenges that we see, in addition to this being all of us experiencing the pandemic, being exhausted and the anxiety on the work, I think the biggest challenges that our staff face are twofold. One is they spend an inordinate amount of time on the phone providing guidance to parents with regards to community and household exposures. So those are exposures that have nothing to do with the school environment. I can tell you at one school, because we were collecting data on this as well, one of my nurses made 96 phone calls in one day to guide parents about situations that had nothing to do with the school environment. They were community and household exposures. That's taxing. So we're finding that nurses are being asked to address, I have somebody at home who's positive, what should they do? I have somebody at home who's positive, what should the rest of the family do? And so that's been tiring. Recently, CDH came up with a quarantine guideline, quarantine calculator, and that's been posted, and that's been helpful and has relieved some of those calls, but they still get a lot of calls and guidance. The second is that everybody's patience has waned, and people are very angry, and so when they do make phone calls to discuss with family members the need to quarantine people are very angry, and some people, quite frankly, aren't nice. And I think that's what takes the larger emotional toll. The majority of our parents in our community are wonderful, but it's those few exceptions that can make things really challenging and add to the emotional toll that we face. And you get 1 or 2 of those a day, and it starts to add up. But I think our staff are doing amazing, but it is challenging.
Thank you. Dr. Bubb, maybe you want to add to the...
Yeah, Madam Chair, Trustee Ozuna. I don't want to speak for every staff member, but here's the experience that I've had and conversations that I've had. And I'm going to kind of take masks out of this, but really put it in the bigger picture of just COVID in general. Because, I just think it needs to be a little bit separated. And here's what I'll say. Our staff are exhausted, and that is everybody. We are dealing with, I don't know any staff member within our schools that said, when I grow up, I want to be a professional contact tracer. If we have them, I will refer them to CDH. But we're exhausted, and we're exhausted from not just the workload. I think the workload is a piece of it, and what we're having is administrators are chasing around contact tracing all day. Nurses are chasing around contact tracing. Different personnel that have been appointed are chasing down contact tracing during the day. And what's happening is they are staying till 11, 12 o'clock at night to get their other work done. And they feel like, hey, I got into this to make a difference in the lives of kids, to impact instruction and to lead my schools. And I'm not able to do that. What I'm doing is I'm doing paperwork at night, and I'm contact tracing during the day, and restart the next day. That's not the rewarding job that I think a lot of people, and if you want to know the honest answer, that's my biggest concern for our staff. That goes away from masks, that is really one of the reasons I've reached out to Mr. Duke to talk about, like, what does this look like long term? Because what we can't have is really, really good staff members. That includes classified, certificated, and our administrators. We can't have them leave education. They're too good for us. My plea to the community is when they call, they're doing their jobs. And, grace and mercy when it comes to that stuff is really, really important. They don't want to make that call any more than you want to take that call. But it's vital that we start treating our staff with care, love, and respect.
Thank you. Other questions?
Yeah, thank you, Madam Chair. Ms. Gardner, thank you very much for your comments and expertise. A couple questions. One is, you mentioned other school districts, and probably you and your colleagues, exchange information. And maybe you don't have the numbers, but what have you found with our other districts around us that are not doing their mask optional and their percent of absenteeism and that sort of thing?
I don't have numbers as in percentages. We know the 3 of 10 are wearing masks. And those that are not, what we're hearing is they're not seeing an appreciable increase in absences or illnesses.
Follow up.
Go ahead.
Oh, go ahead. I'm sorry, Dr. Butler.
Madam Chair, Trustee Kofelt, I did get some informal data across other districts. Our neighboring districts that do not, and I specifically sought to get some data on our neighboring districts that do not have mask requirements, are not contact tracing. Their attendance is, and you can surmise, I don't have a reason for this, but you can surmise what you want from it. Their attendance is higher on average than ours is, their average daily attendance. Our IC report gets turned in at the end of the week. That's when it'll become official, and we can pull that information. We don't have that right now, but in informal conversations, their attendance rates are higher in neighboring districts.
Thank you, and that's all I have.
Okay. Thank you. Trustee Ozuna?
I'm not sure exactly where to direct this question, so Dr. Bob, I'm looking at you to start with. One of the things that I get asked a lot is, what is the educational impact to our kids for masks? And I do think that there are some situations where there's an impact to education for the masks. And I think we have to balance that with when the right time to take this off is. But can you talk to us about some of those situations so everybody's aware of what that might look like?
Madam Chair, Trustee Ozuna. Yeah, I mean, I think there's so many situations in which you can really look at it. I will talk about, and I think Ramona's in here somewhere, maybe, outside. She ran outside as soon as she heard the question. But I think for our special education population, there's some specific needs that kids have where they want to be able to read lips. I will tell you, our American Sign Language classes, it's really important to be able to read lips through American Sign Language. I think there's a lot of different individual cases. I will tell you, being able to, being at schools, I've been able to serve lunch at schools the last couple days, and seeing the interactions between kids, I think is a little bit different. So, I mean, I think you're seeing a little bit of everything. Whether that has long-term effects, I'm not qualified to say that, but I think you see those differences amongst kids.
Oh, go ahead, Trustee Kofeld.
I'm sorry, something else popped in my head. This question really I'll direct towards you, Dr. Bubb, and my intent is not to put you on the spot, so I apologize for that. But as I'm sitting here and I'm listening to our district health professionals and you know, you're with them every day. You're in the trenches with the administrators, the teachers, the staff, and so what would be your recommendation for moving forward that would accomplish our goal of keeping our kids in school learning full time, and also helping to alleviate some of this strain that's on everybody, so we can help get back to educating our kids also? And yeah, just like to hear your thoughts.
Madam Chair, Trustee Kofeld, interesting you ask. I truly think that we can implement a system in which we work on a school-by-school basis. We have schools right now that don't have any cases, and I'm going to describe this, and the parameters could be really clear from the board. If we said something like, we're going to label schools as a green school, a yellow school, and a red school. Green school, and I'm going to throw these numbers out, doesn't have to be what I'm, but green school is less than 1% transmission rate. You guys are mask optional. As soon as it goes yellow school, which is over 1%, that school becomes a mask mandated school or a mask required school. Red school, maybe that's that next step, whatever that parameter is. But I think we can label that. I think that when we heard from our public health officials, they said, hey, what I heard was that would be great if we could dig in to our individual data. We happen to have, I'm going to tell you, when you look at other districts' data, and I do every day because that's my life, I'm going to tell you our data program is extremely robust. When I pull up, you know, not just data programs from the state of Idaho, when we look at data from other districts around the United States, our data, the data that we provide to our public and data that we have internally is extremely robust. Kudos to our health professionals that help to input that data. It's really, really good. But if we started to look at that, and I will give you guys a school district of 20,000 from Alaska, but it's 20,000 kids, very similar geographically, spread out geographically. And I would still argue that what happens at Eagle High School is much different than what happens at Siena Elementary. I think we can handle those things a little bit differently and really get into individual school communities and say, we're seeing spread in this school community. And I think there's some longevity to that. I think we can look at that and say, okay, where are we at with this school community? When it's green, we have lower restrictions, and it kind of goes back to those layered restrictions. When it's green, we have lowered restrictions. There's an automatic trigger for yellow. There's some more heightened restrictions. And then there's another trigger for red where there's more heightened. And if you want to put an orange in there, you could put an orange in there. But you can see where I'm going with that. And we've also seen our health districts provide the same information, right? They have a level red for the entire community, a level orange, a level yellow throughout. And so that's the ideal world to be able to get through this. And then as we see lower spread, as we see some of those things, then we can automatically say, awesome, you guys, and I think that also encourages our kids to take care of themselves outside, because positive cases in our schools hurt that whatever they're at, right? So I can picture a school saying, hey, we're level green, nice, we can go mask optional right now, we're excited about that. Well, then don't go to the Old Dominion concert and sorry if you're Old Dominion fans, but don't go to the Old Dominion concert and be in high risk areas. Let's try to maintain within our schools. I think that becomes a really effective mechanism. I think you could toss some testing in there as well, where, as part of that, we also address quarantines, where we're going to say, okay, listen, you need to test after 3 days, which we have that capability to turn on. We are doing it now. We could turn it on for certain specific situations on a regular basis. I think we could really put an effective system in place on a school-by-school basis.
Thank you. Any other questions? Trustee
If I can
Kloppenstein.
thank you very much, Madam Chair. I just want to respond to that. But what Mr. Duke said was that he would like to see, or at least it would be ideal, that our response include cases in community in percentage or cases with hospitalization. So something that's been over the last 19 months has been the idea that our buildings are somehow separate from the community. And I think that's where you're going, is that the buildings would be separate. Is that kind of your idea, is that kids come to school and where they are is a protected space, mask or no mask?
Madam Chair, Trustee Kloppenstein, absolutely. I think that's a fair critique to that program. I mean, yes, absolutely. What we'd be looking at is a school-by-school basis. We'd say we want to take care of the community spread within our schools. Very much the same as what our community is doing right now. We would reflect what our community is doing right now. If they're green, if we're not seeing major spread at Costco, then there's not a mask mandate at Costco. If we're not seeing a major spread at the Boise Mall, then there's not a mask mandate at Boise Mall. If all of a sudden we saw a major breakout at Amazon, sorry if you work for Amazon, if you saw a major breakout at Amazon, all of a sudden there'd be a mask mandate there, and that's where CDH would be able to give us some guidance on that. So yes, you're correct. That's a fair critique.
So in other words, your idea would also include cases in the community and hospitalizations.
Madam Chair, Trustee Kloppenstein, no, that would not. And so, I mean, I think that becomes that next step. So I took the question as, when we get out of this, what does that look like? If you guys said, hey, let's implement this, let's go to this school-by-school basis, then I could start that, then we could do that.
Let me clarify. So what you're saying is, when we get out of the current spot, then go to that? So right now we're in a district. Because I didn't understand. I needed to clarify that. I don't understand.
Madam Chair, I would love to go to it right now. I think we can handle this on a school-by-school basis. I'm of the belief that we have our kids in masks for 20% of the day. 80% of the time, they're not in masks. They're out in the community. They're doing other things. I think we can handle that 20% of the day on a school-by-school basis.
Thank you. Okay. Any other questions? I have a couple for Tracy. Just quick ones. Tracy, remind me again how many, we've been in this 19 months. How many months have our kids been unmasked in that time frame?
2 weeks.
Okay. So all of our data is based on kids being in masks today?
West data, yes.
Okay, thank you. And then Derek, I have a question for you, Dr. Bubb. Tell me the why behind your recommendation, because I think that's an important thing to hear.
Madam Chair, I really liked what Dr. Turner had to say as far as what local control looks like, and the idea of why the health districts haven't stepped in, the idea of why Department of Health and Welfare haven't stepped in, because one area is vastly different than a different area. I think, and I'm going to misquote you on this, so I corrected your stat. You can correct my stat, but West State School District is bigger than 35 of the counties in the state. Is that fairly accurate?
Madam Chair, Dr. Bub, so if you look at just your student population,
Fair enough.
to be very specific, it would be bigger than 34, the population. And then if you add in your staff, it obviously closes that gap even more.
So, perfect. So 34, we're treating a large population as if it is the same from one section to the next section. And so I think one of the things that Dr. Turner has said is, as you can hone in on smaller populations, the more effective you can be at managing this. There's nothing better than being able to hone in on a smaller population like a school. That's a great population to be able to hone in on. And we've gotten, this isn't like, oh, let's get some new data on that. We have that data. We have effectively been able to foster that data. Our again, medical professionals have done an amazing job trying to get that. And when we can deal with schools on a school-by-school basis, we have a lot of schools that don't have any cases on their campuses right now. This would be an opportunity to be able to, going school by school would be an opportunity to say, okay, awesome. You guys can go mask-free, and we know we can, or mask optional, and we can pivot in a second when we say, hey, you guys are gonna go yellow now. You've had some outbreaks. And then I think we can constantly look at this to say, is this effective? When I look at a school district that I use in Alaska, that what they have done, when you look at their cases, they have done a very effective job managing it. They have one school in red right now. They have a few schools, and I don't know what what the exact numbers is, but it's something, and we can manage those numbers. We can look and say, so I think that becomes a board discussion on if that's something we're interested in.
Thank you. I think my question and my last question is so I think what I heard in that recommendation was, from an operational standpoint, we can manage it this way. What do you say because we have parents on all sides of this issue, what do you say to the parents who don't have kids that could get access to a vaccine right now and who are not comfortable in that situation from your school operations standpoint? How do you suggest those parents get comfortable, or how are you suggesting, what do we say to those parents?
Madam Chair, yeah, I mean, that would be I think that the green, yellow, red is extremely parallel to what our health districts do. And so if our schools are in green, just like if we lived in a very small county, the whole county could be in green. If our schools are in green, then we stay in green. To a parent that was uncomfortable with that, they should know that we would be able to pivot into a yellow category in a second if we saw that. We'd have it on a daily basis where we could look at that data and say, okay, we saw 2 cases here. And then we'd also get a track record of, are we moving kids back and forth? Yellow, green, yellow, green, yellow, green. We'd get some really good data from that almost immediately.
Thank you. Trustee Ozuna.
Dr. Belver, maybe Ms. Gardner. We know that kids have low disease severity and are often asymptomatic. If we're in high community transmission and we're not doing bulk testing in our schools or surveillance testing, that's not something that we're doing, what are the chances that our school numbers are higher than what we're reporting? I think the chances of that are really actually pretty high, that those numbers are understated.
Madam Chair, Trustee Ozuna, I mean, I could only make assumptions. I would not know what that looks like. I will tell you that according to health professionals, that we're testing a record number of kids. So I don't think kids, I think parents have been very good about, I'm not going to say every parent, but there's a lot of parents out there that have been very good about, hey, my kid's symptomatic, I want to find out what's going on. A lot of times it's allergies. We did test. I mean, I think a good barometer is we tested, and I'm going to mess up that data, but 400 kids with 28 positive. And that's
28 were.
So that gives a.
Thank you. We are past the 9:30 mark, so as long as the board's comfortable, I think we would go into some board discussion. But do you guys need a break, a real quick break, or are you good? Yeah, let's do literally like run to the restroom and come back kind of thing. Thank you. All right, back from break. You know, I don't really have a plan for how you guys want to do this. I thought maybe we'd just start with kind of where you're at, what your thoughts are, and see if we have some consensus or not. So I'd open the floor up for discussion. Trustee Ozuna.
Madam Chair, are we doing a hard stop at 10?
That was our, I think we posted it that way.
Okay.
Did we post it that way?
Madam Chair, I did not post it that way.
Okay. Well, that's good to
But
know.
that's our intention. Okay. I'm going to go
Okay.
fast. Dr. Bob, I like your idea of school by school. For me personally, I wouldn't be ready to make any changes while we're in crisis standards of care. I feel really strongly that we all have a community responsibility to take care of the situation that we're in. That is just core to my beliefs. I have mixed feelings about vaccine availability and the ideas around that, and I'm sensitive to some of the conversation that we had here tonight. I also have concerns around the community spread numbers, and I don't know what that exactly looks like. I would assume that as we come out of crisis standards of care, our community numbers are also going down. So I don't know for me if the decision-making there is an and on those or if it's an or, but those are a couple of the things that would hold me back from being ready to go into school-by-school discussion. I would like to continue on, though, to have, I'll let everyone else talk first, but to look at potential changes to how we look at quarantines and contact tracing, because I think there are opportunities there.
Other trustees? Trustee Buffy.
Thank you, Madam Chair. Like Trustee Ozuna, I'm not comfortable with the recommendation. I appreciate the recommendation, and I'm a little confused by it, though, to be honest, because I thought that part of the reason we were here was to help alleviate some of the stress on administration, and we're recommending, you know, to design a plan. I'm struggling with that, so I would not be supportive of the recommendation. I think that we need to keep our primary focus on education and be sure administration is able to do so as well. But with that said, I mean, the board has a statutory obligation to protect student health and to manage infectious disease in our schools in consultation with Central District Health. And I think to protect student health and keep our students in class as much as possible, I believe we need to adopt CDH school guidance as developed by public health experts. We are not public health experts, and so I'm not comfortable with redesigning the matrix and data points when we have recommendation from those that are public health experts. Thank you.
Thank you. Other trustees? Trustee Kofelt.
Thank you, Madam Chair. Yeah, and I appreciate the comments that my colleagues have made. Where I struggle a little bit, and Trustee Ozuna touched on this, and I wholeheartedly agree, and Mr. Duke did too, that, you know, public health is about community participation. You know, nobody can do something by themselves. But then I struggle with, we've had a vaccine available for adults for quite a while now. And our community has pretty much established where their participation is going to be. You know, we're at a 60% rate. At the last time I had checked, the state of Idaho is like third, I believe, below Alabama and Mississippi on vaccination rates. And they've been available for a long time. Our 12 through 18-year-old students have been available to get a vaccine for a while now. And I think the number that was used, and correct me if I'm wrong, Mr. Duke, was like 25 to 30% vaccination rate. So I think if everybody was participating from a community standpoint in this, I might have a different perspective. But we're putting this entire weight to participate on a group that is the least affected. And I get the point of they may take something home because they can be spreaders. I fully get that. But the people they're taking it home to have the chance to have a vaccination, and they've chosen not to. And that's not to say that one life is not tragic to be lost, but I just really struggle with putting this burden on the group that's least affected when those that are being affected have a solution. They have a treatment. They have an option that's not 100%, but it's very, very effective. So I'm supportive of moving more to a mask optional position, but only if we can make some tweaks to the exposure policy, because as we saw before, our exposure policy, where if you weren't wearing a mask, you're home for 10 days, that's just not effective. That was very, very disruptive, and that defeated the purpose of keeping our kids in school and learning, which is really the most important thing, is to give them a high quality education. So I'll leave my comments there for now, but I have a thought on how I would like to move forward, but I'll just throw those out there for now.
Thank you. Trustee Kloppenstein?
Thank you very much, Madam Chair. I have to admit, I think some of what I like to go back actually to your North Star. What is our goal here? We're trying to keep schools open 5 days a week so the kids can stay in school in person. And I think it's important for us to understand hospitalization and community infection rates, because it's affecting the number of bus drivers we have, being able to get kids to school. It's affecting our aides. It's affecting our volunteers. It's affecting our overall community. And we don't have schools in isolated pods. Kids transfer back and forth. I mean, we have a very mobile environment here. And so my concern is by not adhering to guidance from CDH or other agencies, or not listening to our healthcare professionals, that we may go back to a situation where we're exposing our bus drivers again. So poor Mr. Heller is going to have to be riding buses or driving buses or serving food or what have you. Or we've got other issues where we have to double up staff. When we have a teacher out and not enough subs, that means we have 2 teachers have to pull out to support that room. We have these doubling up of being able to do the basic task of delivering education. It's just the basic logistics became more difficult. And again, there are probably other things involved, but bringing masks back in did seem to make it easier. It's not great. These are awful, I do agree, but at the same time, show me, I guess, I really want to see where not having something is going to make sure that we are keeping kids in school 5 days a week in front of teachers. And I just think it's, we're not health experts. We can create ideas and systems that might seem good, but by not listening to the health experts, it just feels to me like we're missing an opportunity to do what we need to do. And going back to keep kids in school, and going back to what you and others had said about our community, I totally agree, and I am so frustrated. I mean, frankly, there should be protests in front of concerts. There should be protests in front of, in front of malls. People not wearing masks. Why aren't they wearing masks? Why aren't they supporting the kids? Why are they going to a bar, without a mask? It's just ridiculous to me. And it's ridiculous that they're putting all this emphasis, all this weight on school boards and kids and teachers, when in fact it's the population that's least able to really help. It really comes back to the community itself. And the community, it feels like it's abandoned us. So I'll leave my comments there, but I do say that I think we're a bit too early yet to go back to a mask optional. Thank you.
Thank you. So I think we have to acknowledge, like, I want to acknowledge one thing. I don't think any of us wants kids in masks. Like, I don't think that's anything any of us wants. I don't think we want to see anybody in masks, right? If we could all go back to pre-pandemic, we would all say, yes, please, right now. So the question is, how do we maintain our North Star and move to towards a mask optional? What does it look like for us to get comfortable with that? I think was the question we were trying to get to. And I echo some of the same concerns about the frustration of this only being on schools, although I kind of now really have some empathy for Central District Health, because now I understand that actually the way our system, our law and our system and our legislature and our elected officials at higher levels set us up, they all set us up for this. And so that's a even bigger frustration, but I don't hold it at Central District Health anymore. And we've heard this a number of times. We're not public health experts, so so we shouldn't be making public health decisions. So then we bring in public health experts, and then we say, well, okay, but now we're going to go against your public health recommendation. And so I'm struggling with that too. And I guess I'm thinking kind of the method that we've used throughout this 19 months, and 3 of us at least have been down this path of finding a balance between the public health recommendation and the school operation recommendation. And we did it to get kids back in school. We went against public health recommendation and put kids back in school last year. We went against public health recommendation. We went based on school operations and put 6 through 12 in full-time last year. We did that because at that time we found a balance and a way to do it safely. And so I guess what I would look for us to think about, what does that look like for us? Where's the balance we can strike? I think an Ada County vaccination rate of 70% for those who have an option to get it is phenomenal. That is beating the state average by 15%. So that to me says a lot about, at least maybe our community isn't wearing masks, but they're definitely vaccinated. So why can't we look as a balance and say, if our community is that rate, I'm comfortable that when our kids all have access to a vaccination and parents have that choice, I'm more comfortable looking at a mask optional status. Because I think if you watch the trends on vaccines, not everybody comes at once, but they do get there at some point, and not everybody will. But we're doing pretty good in Ada County. So I think if your parents are doing there, they start to see some data around how kids are doing. Sometimes it takes some time. That's one. I'm more open to looking at the contact tracing differently. I guess I'm struggling with how effective contact tracing is in high rates of community spread. I just don't know how effective it really is. I'm more open to the quarantine options. So I guess I would say, for me, if I look at the question before us around how do we move to more of a mass optional, it'd be having vaccine availability to all of our school-age kids. It would be then doing, that's the first one. I am struggling with the crisis standards of care one. I have kind of mixed emotions on it because I agree. I think we are part of a community. We're as big as 34 counties. So we have that too. So I'm open to some conversation on that. I'm open to some conversation around quarantine ideas and contact tracing too. I don't love the idea of us having to make these public health decisions, but I think that's what we've been doing and doing a pretty successful job at it. When we've kept that North Star piece in mind. So I'll stop there and say it. Yeah, Trustee Kofelt.
I'll float a concept out to my colleagues here just to create some discussion, but in search of that middle ground, as you mentioned, Chairperson, and listening to Ms. Garner about our conversion rate on exposures has only been about 0.5 to 1.5% pretty low. And yet, we've been, when we were mask optional, we were sending a tremendous number of these folks to sit at home for 10 days. And this would be something we would try and see the results. So we go back to my suggestion for discussion would be a mask opt-out like we had before. And if there's an exposure, that exposure goes into a mask for that 10-day period. And as long as they remain symptom-free, or on day 4, if they go do a rapid antigen test and they come back and show that to the school, then they can get out of the mask even before the 10 days. I think it accomplishes, one, the vast majority, and I'm basing this on the number of people that did the opt-out, are still going to wear masks. Those that don't, if they get exposed, they're not going to be outside of school. And I don't think that's being reckless, because our conversion rate is very, very low. And then we see how that plays out. So I throw that out there for discussion.
Yeah. I really need us to clarify this, and Ms. Garner, I really wish you had said this with it, because I think it's the fair and balanced way to say it. That's our conversion rate with masks on kids all but 2 weeks of the school year, correct?
Yes, but I also hesitate to say that with all the infection prevention measures, that's the reason. Like, we don't have that data to say that was the reason.
Yeah, so I'm asking our data
That's an
today,
assumption.
what we know today, known data today, is 0.05 to 1.5% conversion rate, and we know we had masks on, we know we did hand washing, we know we did as much social distancing as we can.
Yes.
Those are the prevention measures we had in place. We know we had contact tracing full-time, and we know we had full quarantining full-time. Those are the prevention measures that were in place with that conversion rate, correct?
Correct.
Thank you.
Madam Chair, with Ms. Gardner, do you happen to have the numbers when we went to the mask optional? And you may not have these, but that period of time when we were, if you had your mask on, you quarantined at school. If you didn't, you went home. How many of those kids converted?
I don't have it right now. I could probably calculate it in about 5 or 10 minutes. And then the other is that, one of the variables was distance. So we're constantly looking at data. So with regards to what you said, the distance was, originally we did the 6 feet in the mask, and we've been shortening distance too. So variables are changing slightly, but we're doing it in a systematic, intentional way, allowing us to examine that data. So we could do the same with masks.
And Trustee Gofeld, don't get me wrong. I'm listening to what you said. I struggle when we don't give the full story, when we give some data and information. And so that's why I want to make sure we all have the same context and understanding in that. So Trustee Gofeld threw out some options.
Just for discussion.
Yeah. So. Trustee Ozuna.
Trustee Gofeld, I think that's a fine discussion to have when we're ready to be in a mask optional environment. Then I do think that there's opportunities there that could be different. For myself, I'm not ready to move into mask optional. I do think for discussion purposes, just after hearing it where everybody was at, I wonder if it would be worthwhile to look at, can we come up with some criteria? This is what it's going to take to put us in a mask optional situation, or maybe these are the triggers that are going to have us revisit the conversation. And I don't know which of those might be best.
Are you guys comfortable with going down that path? What's the triggers to get us to a mask optional? Or mask optional discussion, I guess. Yeah. You guys, you good with that? Trustee Buffy.
Madam Chair, thank you. I mean, like I said, I would prefer to trust the public health experts and their guidance, and not try to design our own plan. I think that I know that I cannot discount parents that come to me and they have real concerns about their students' health, and they're not going to be comfortable in a optional mask environment until they've had an opportunity to fully vaccinate their children. And so that's where I'm at. Yeah. So, I mean, we can have the discussion, but.
Trustee Ozuna?
Can I ask a question to Director Duke?
Sure.
Around, if we were to look at public health guidance, so I think that's really looking at you, how often are you reviewing your criteria, and what does that review process look like? Would you be reviewing as soon as crisis standards of care are over? Are you reviewing as soon as vaccines are available for these younger kids? Are you reviewing every time community transition drops a level to redo your guidance for schools? I would hate to put us in a situation where your guidance is out there and it's complete and it's set for the year. That would not put us in a very good place if we were to go down a path like Trustee Buffy's recommending.
Madam Chair. Trustee, one of the things we learned early on was trying to micromanage this with this closure and that event and group sizes. It ended up not making any sense. I think to the points that some of you have made with widespread community transmission and the complexity of 30, 40, 50% of people being asymptomatic but still able to spread it. This disease is really quite unique. So to get to your question, we're currently using the guidance from our National Public Health Agency, which is recommending the K through 12 wear a mask indoors. And as far as evaluating that, certainly if our cases, what I talked about, drop pretty dramatically, and our hospitals, they'll likely always have some COVID-caused patients in the hospitals, also drop. I'm not going to be able to continue to support CDC's recommendation if that happens, let's say in November or December. So we will come out, we'll work closely with Department of Health and Welfare, the folks who spoke to you earlier, Administrator Shotalik and Dr. Turner and Dr. Hahn and others, to come up with some more practical and reasonable approach that applies to us. I think right now, as I mentioned, it makes sense because of the severity of the situation we're in, and I do think we need to be planning for those circumstances. So we don't look at it every 2 weeks as far as masking. I guess that's, kind of the issue on the table is we're continuing to follow CDC's recommendations, and that's why I had suggested if you're going to make that change, I certainly wouldn't recommend you do it today, but if we see a good decline in cases and hospitals coming out of crisis standards of care and those trends just continue to decline, then those will be policy decisions that you're charged with making now. And I'll be glad to come back to and make a recommendation.
Thank you. Trustee Ozuna?
Can I do a follow-up to that? It sounds like we could be in a potential situation where you could support a mask optional environment before the guidance from CDH or CDC changes.
Madam Chair, Trustee, I absolutely would. I think that's looking at I think that our response needs to match what we're seeing in our community. That's kind of the bottom line. And right now, I very much align with CDC's recommendation because of what we're seeing. And once we move beyond this, which I 100% believe we will, hopefully within a month, some kind of time frame with the trend continuing, then we need to revisit it.
Thank you. So, Trustee Kloppenstein.
Thank you very much. Just going back to what Director Duke had said, it just, to me, it just means if we were to give this without additional strain and stress. So, thank you.
Thank you. So we went past 10. How does everybody feel about that? Why don't you just give me a, keep going or not going, so I know. You okay? Look at you guys. You like to make decisions after 10 o'clock. Trustee Kofelt.
Thank you, Madam Chair. I guess what I'd like to ask my colleagues then is, what what are your thresholds for when you're comfortable? If we're waiting for the kids to have the opportunity to be vaccinated, and only 30% do, which is what we have right now, we're going to have a whole lot of kids that aren't vaccinated. But are we going to feel better about it because they had the chance? Because the adults have had the chance, and they haven't. And that's the ones that we act like we're trying to protect. And if they were all vaccinated, kids wouldn't be an issue. So I'm not sure what we're going to gain. So I mean,
Well, that
I'm
one
just
seems
trying
a
to
little
pose-
pointed at me, Rusty. You want me to answer that one?
No. Yeah, I'm just
So,
frustrated.
well, yeah, well, boy, I feel you, totally. I can speak only for me. So I think 70% is a high vaccination rate for those who have access. Now, I know the kids in 12 to 18, but I also understand the parent concern around it hasn't been out that long, right? And so, and right now, some of those folks, their kids are in school with masks on, some aren't, right? So I don't want to question it. I guess I still go back to keeping kids in school. And for me, the vaccine piece is around parent choice. So right now, a parent, there is about half of our kids and those parents don't have a choice for their kids to even protect themselves with a vaccine. And so I kind of balance, personally, there's the public health side of things, and then there's the personal choice side of things. And frankly, because now I understand our public health system isn't even getting real choice to manage community health, it's really falling on community choice and schools. And so I'm wanting to look to get it off of schools, and if I can get it to community choice all the way through schools, then I feel more comfortable with, like, it's an individual choice, you're taking your own risk. Now, that being said, I struggle with where we're at from our hospitalization standpoint, because if our kids can't get services in the hospital when they need it, or our students who are athletes get stuck in a situation where they're injured on the field and it's hard to get a service in a hospital, that's going to impact them too. So I'm open to that balance because I see that side of it too. But if it's just the black and white, the choice is an important part for me.
Madam Chair, okay, so if the community part aside, because I know I can't remember how many weeks ago it was that we reinstituted because the state was on the verge of going to crisis care management and subsequently did. I don't believe, correct me if I'm wrong, and that's why I kind of asked the question to Dr. Turner, I don't believe that situation in our hospitals has changed much. So we put our kids back in mask and it really hasn't changed. So I don't know how valid the impact of us putting the kids back in mask had on that. And the other piece to it is, I can understand the vaccine piece, and if that's the case, then why don't we look at making a different quarantine policy for those in 7th grade and older, and then we can see how that works. And then when the vaccine's available to the lower grades, we can roll that out to them. I mean, because they've had the chance to be vaccinated.
I'm personally open to talking through stuff like that.
If I could just
I think
jump in.
actually, though, I will tell you, I think you and I are closer to each other. I think we've got 3 other people who are a little past us, so I don't know if you and I. Yeah, so. So,
Oh, yeah, that's good.
Trustee Kloppenstein.
Thank you very much. Going back to what you're saying, it's like logistically, because we had the conversation early back in the beginning of the school year. Could we actually separate grades up to a certain age? And unfortunately, middle school, no. Because you'd have to go from, it would have to be 6, 7, 8 as a group, and so whatever we do for 6, we'd have to do for 8 because it's middle school. So it's just a logistics issue for me. So, and a lot of this is logistics issues, right? It's like, how do we make it easy on teachers so they can support our policy, right? So it's not adding additional burden and stress. How also can we make it so that we're not creating a situation where suddenly in 2 weeks we see, oh, we're running out of bus drivers again, we're running out of food aides, we're just running out of people. You know, maybe they didn't get the vaccine, who knows, but they didn't, we still need them. And we're already having a labor shortage, so it makes it more difficult. This is going back to making sure we have people in the schools to be able to staff the schools. That's part of the issue as well.
Trustee Kofel.
Thank you, Madam Chair. I get to kind of go with Trustee Klopfenstein's perspective is, and I would pose the question to Dr. Bubb, would that logistically be troublesome for administrators?
Yep. Madam Chair, Trustee Kofel, I'm going to defer to our resident middle school principal to let him kind of chime in on that.
Thank you, Madam Chair, trustees. I would actually say I don't think it's logistically would cause that huge of an issue. Sixth grade, in many ways, operates almost as if it's its own little entity within a middle school. They don't share classrooms very often with 7th or 8th grade students. There are some rare occasions where that does occur, but very small amount. I think you could run parallel quarantine plans at the 6th grade level with a different plan at the 7th grade level and not create huge logistical challenges for our buildings. I think they could manage that. Lunches are separate at the middle school, so your 6th grade lunch is a different time than your 7th or your 8th. So I do believe you could do what you are suggesting, Trustee Kofelt, without major logistical challenges for our buildings.
Can I ask Trustee Kofelt, are you looking to do that now, or are you looking to do that after a vaccine's available? I wasn't sure.
Oh, no, I would be looking to do that now if it doesn't sound like, you know, there's going to be the majority to support going to some sort of a mask optional policy district-wide, and I can appreciate the concern of some parents and things with their kids not having had the opportunity to be vaccinated. And I'm going to look this way now, so my back's not to you, Ed. As a middle ground, perhaps with the kids that have had a chance to be vaccinated, I do not want to create more work and difficulty on our administrators. But we move to that, and then we wait for the vaccination, and then we could take that policy and roll it right into those lower grades once they get it.
So when I said I was open to it, I am open to it. Here's what I'm struggling with, and Mr. Heller, you correct me if I'm wrong, but middle school, I don't believe you've been a middle school principal managing during COVID.
No, ma'am. No, I have not.
Okay. So I would like to hear from our middle school principals, which is where the biggest consternation would be around managing it. I happen to have a child in middle school right now and watch how that works, and I'm struggling to see what that operationally looks like just watching it from a parent standpoint and managing it. So I think if we were going to go down that path, I would like to see a plan from the experts, I guess, for that one. But I'm open to it, so I don't want you to think that. So. Oh, sorry. Thank you. I need to be right there so that I can look down this way. Trustee Buffy.
Thanks, Madam Chair. I'm hearing you and everything, but then I'm going back to contact tracing, and we need to alleviate some of that burden. And I feel like if we're doing mask optional, then that's in direct conflict with that. And so how are we going to alleviate some of the contact tracing for our staff if we're also doing mask optional for some certain grades? And I don't know the answer to that, so that's why I'm looking at you.
Trustee Kofelt, did you get are you answering that one? Oh, you were passing it down the line.
Madam Chair, yeah, I'd love that's a great question, and so if we could have Ms. Garner maybe comment on that.
So as I've already explained, we've been constantly already looking at data and evolving. We've talked about this at the beginning of the year. So we've looked at, can we safely decrease the amount of distance? We talked about contact tracing to distance and time, and we've decreased In about week 3 or 4, we decreased it. It was week 4, actually. We decreased the distance in our contact tracing from 6 feet to 3 feet under the recommendation from CDC that kids can be safely in school at 3 feet. And we have not, again, then we watch and monitor the data. And so there was no difference. What it does do is it decreases the number of students that we have to identify, and it decreases the number of notifications, and thereby it also decreases the number of students that need to quarantine. So we've done that since the beginning of the year, since week 4. So I think that does help. You asked about numbers. The numbers was 0.78% conversion rate those first 2 weeks without masks. So it fell within the range that we've been operating under. It was a 2-week period though, so that's a limited time frame.
Well, what's the will of the board? Trustee Ozuna.
I thought during the conversations tonight that I heard support for perhaps dropping or changing contact tracing if we were in a mask-required environment. Because in a mask-required environment, the contact tracing results in quarantines that happen at school with still masks on. If we could get to a situation where, if we're in a mask-required environment, there is a positive case at a school, and we did either a classroom notification or a school notification, whatever that looked like, would that alleviate some of the pressure on the team that's doing that?
Would it alleviate? Yes. Now you lose controls of being able to collect data and make decisions off of data. So now you have no ability to identify who the close contacts were and whether they converted or not. So you lose all other controls in the environment.
And I guess I'd follow up and ask, if the conversion rate is so small, does that matter? Is that?
Maybe not. Yeah, and then you have testing as another option. So, yeah, it sounds reasonable.
Trustee Ozuna. No, go ahead. I was just calling you.
I was going to say, so to take that a step farther, if we could get to a situation where, what are the criteria that we might want to look at to go to a mask optional environment? We could alleviate pressure on our staff by changing contact tracing. I don't know if we need to look at quarantine procedures at all in that then, because they're quarantining at school. And then the conversation might be, what are the triggers for us to have a conversation for when we can go mask optional? And then at that point in time, contact tracing would be much more doable, because we would have some assumptions there that there's probably lower community spread at that time.
Do you want to throw out some triggers?
Out of crisis standards of care in our hospitals. A potential trigger could be vaccine available for 5 through 11. Another trigger could be related to our community spread. Those are the ones I heard tonight that I think would make sense. Any or all of those 3.
So let me see if I repeat what I think you just said, just so we can say we're all on the same page, and then maybe talk through some feedback on that. So while we're in mask required, we would go to the removing of the contact tracing now to alleviate some of the pressure on staff and do classroom notifications out to parents with the request to, monitor for symptoms and keep them home with symptoms, and then testing would be the other piece of that. Did I got that part right? Current situation changed like after tonight. And then some triggers for us to come back to a discussion around mask optional. There's 3 options in any variability could be 1, 2, or 3. But the 3 you heard support for were out of crisis standards of care, would trigger us to go back to, or have a discussion around going to mask optional. Vaccine availability would trigger us to go to a discussion around mask optional for 5 through 11, and a community spread trigger that could trigger us to go to mask optional. Did I cover that all right? Okay, so maybe some feedback on that thought. Trustee Buffy, sorry.
Thank you, Madam Chair. So I would ask about the hospitalization, since that was the other point that Director Duke brought up about being a trigger. And then my other just comment about the vaccine availability for ages 5 to 11. We gave our teachers the opportunity to be fully vaccinated before we started bringing the kids back 4 days a week. So I would like to make sure that they've had full opportunity to be fully vaccinated and taking in the time for them to get in and get vaccinated like we did with the teachers.
Thank you. Other feedback? Trustee Ozuna.
Can I clarify on, Shani, you mentioned the hospitalizations there. How does that differ from crisis standards of care? What are you looking at as a trigger there?
If they correspond, I didn't realize that they were corresponding though with Director Duke. Would you comment on that? Do they correspond directly?
Madam Chair, so the question is, do the health system, do the leadership of the health systems communicate with Central District Health and with me?
No, go ahead.
No, so when you talked about the trigger for number of hospitalizations, is that directly linked to or corresponds with being in crisis of care standards?
Madam Chair, so my recommendation is that while the hospitals are in crisis standards of care, I would not even consider going with a mask optional policy. That would not be a recommendation that would come from me. Once the hospitals are out of crisis standards of care, that's St. Al's and St. Luke's, and we see sustained decline in transmission, and what I would throw out there, and this doesn't align with CDC's guidance, is if we get to moderate levels of transmission as published by CDC for Ada County, that's when I would have the discussion. If you're going to do something different and follow CDC's guidance, that would be sort of that minimum standard, that threshold to have the conversation about mask optional.
Thank you. Okay, I'm following now.
Yeah, Trustee Kofel.
Director Duke, is there any data to point to that supports that the adults that are in the hospital, parents, whatever, are getting it from their kids?
Madam Chair, I would say, Trustee, the answer to that is there would be no question they're getting it from all family members. That's where we see a lot of the transmission occurring, as was noted earlier, and it's very difficult today to identify where people are getting infected, because sort of the statement I hear some public health professionals make is, if you're out in the community and you're around unmasked people, vaccinated or unvaccinated, when you have high transmission, you're being exposed. So it's extremely difficult for us to pinpoint that's where the exposure occurred. Back on March 25th of last year, no problem. But now it's next to impossible. But the transmission is generally occurring from kids to parents, parents to kids, both in the home environment and then in the social environment they tend to interact with.
Thank you. Trustee Kofel.
Yeah, I mean, I can only imagine the difficulty in trying to trace this with packed Boise State stadiums, packed Ford Center concerts, all all of these events going on, and somehow I just have trouble believing it's coming from the school, but that's just me. So all of this other stuff going on, and I just cannot see that us keeping the kids in their masks 20% of their day, because they're only wearing it in the classroom, is impacting the hospital situation and the school. I just have trouble seeing that, because literally they're in their masks 20% of the day that they're at school. That's it. So that's what I'm just struggling with.
Maybe can I ask you a question, Trustee Gofelt? What do you think of Trustee Ozuna's thoughts?
I respect Trustee Ozuna, and no, I do, and I think it's a measured approach. I don't, but I myself cannot support something that does not move us in a direction of mask optional. So I would not support it. I support Trustee Ozuna, and I think there's some rationale to it, and I can appreciate that, but I'm just kind of headed in a different direction.
Thank you. Maybe because I figure we might as well just go down the line. Trustee Klopfenstein, what are your thoughts?
I totally support what I thought what Trustee Ozuna was, her beliefs, her concept here is very good middle ground. It seems to me, based on what CDH and CDC is directing us, and gives us a good, a measured approach that would give people an indication of where it would go when things on the ground start to change. So I would agree with it.
Thank you. May I ask a question? Of the triggers, do we only have to hit one, or do we have to hit all three? What are your thoughts on that?
I think that's a great question. For me, crisis standard of care is a big one. It's an absolute for me. But I'm struggling a little bit with trying to come up with, is there one set metric, or is it that any one of these three things could cause us to have a conversation, because things could look different. I don't want to necessarily I don't want to keep coming back and having this conversation. I think it's divisive for our parents and our teachers and our staff and our school community, and I am not hugely in favor of bringing this conversation, continuing to come back to it. But I also don't want to set something that's so restrictive that we could move sooner. And so I'm almost wondering if it makes more sense for us to revisit at any of those three data points. Crisis standards of care is removed. Vaccine mandate is available for kids, which can cause a conversation, but I think you're right, we have to give time for that to be put in place. Or community spread hits the moderate level, which was your recommendation, Director Duke.
Thank you. Trustee Buffy.
Trustee Ozuna, you said vaccine mandate. I think you meant vaccine availability. Okay.
Yes, thank you for correcting me. I'm not suggesting a mandate. Thank you.
And that's what happens when we go after 10.
Right.
And I would say that I agree with the crisis of care, but I will say that my absolute is the opportunity for our parents to have the choice to have their kids fully vaccinated before we go mask optional.
So I support this, and I actually align exactly with Trustee Buffy. So I think it's a good middle ground. You guys want to keep going on discussion, or you want to move on? All right. So we have possible action relating to mask requirement, quarantine procedures, and/or contact tracing on the action item agenda. And the floor is open for motions, or if we need a quick break to make one, that's okay too. Want to take a quick break? Okay, let's, is 5 minutes enough? Okay, perfect. All right. We'll give 5 minutes. Okay, we'll come back, we're in the action item section. I lost my screen. You're okay. I got a paper copy here, Troy. I can manage off of that. We're in the action item section of the agenda. Possible actions relating to mask requirements, quarantine procedures, and contact tracing. And the floor is open for a motion. Oh, except for we don't have screens, so if it's coming up on the screen. Yeah. Gotcha. For the record, I think you actually have to make the motion, just so. Trustee Ozuna.
Thank you, Madam Chair, for the break, and Mr. Heller for typing this up for me. I would move that masks continue to be required in the classrooms. When positive cases are identified within the school, the district will provide notification to all students and parents from the classroom that the positive case occurred, I think, right? The district will revisit the mask requirement when any of the following triggers are met. Crisis standards of care removed from St. Luke's and St. Al's hospitals. Vaccine availability for all students aged 5 to 11. Both doses in the required inoculation period, or moderate community spread.
Thank you. Is there a second? It's been moved and seconded, the motion as read. I think we had one. Troy, are you able to make a change? It says where it says attended, it should say occurred. That's what Trustee Ozuna read.
I reread it. I think attended is okay too.
Okay.
Sorry. Thank you.
Okay, so we have a motion on the floor. Is there any discussion? Trustee Buffy.
Thank you, Madam Chair. I know I've already said it like 2 or 3 times, but I am supportive of this motion, and the vaccine availability is going, if the next time we visit it, and if it's not one of the triggers that were met, I'm still going to have a hard time with lifting the mask requirement. So I just wanted to say that one last time. Thank you.
Thank you. Any other discussion? Trustee Kloppenstein.
Inoculations misspelled, I'm sorry.
Somebody went to school. I just have a quick question of clarification. On moderate community spread, are we talking Ada County, or are we talking all of Central District Health? What's our area of focus on that piece of the motion?
I would clarify Ada County.
Thank you. And then crisis standards of care, I have another question on. Let's say they remove statewide crisis standards of care, but St. Luke's and St. Al's still have it individually, which could happen. I just want to make sure that's what we want. I guess I'm just asking that comfortability question. And that's what your intent is from the motion. Okay.
I just need additional clarification on the intent. I'm sorry.
Okay. Trustee Buffy.
My intention with that one is crisis standards of care no longer exists at St. Luke's or St. Al's hospitals. And I should probably clarify too, that's within our area as well.
Thank you.
Madam Chair, really quick, I just want to make sure, Troy, it's not your changes are not coming up, are they? Okay. Do we want to change, I just don't want to lose track of those changes. Do we want to change the attended to occurred?
Our
Madam
resident
Chair.
attorney, Amy, would you give us some feedback?
Yes.
Thank you. Okay.
Sounds fine.
Okay.
Brett, can you add moderate communities?
Troy's got
Wait, hold on. Why don't you withdraw first, and then we'll do that.
Madam Chair, can I withdraw my motion, please?
Yeah. Thank you. The motion is withdrawn. And now the floor is open for maybe a quick adjustment to the motion. So go ahead, Trustee Ozuna.
That's correct. And with crisis standards of care, I think that would also be in our area on bullet number 1. Treasure Valley would, I think the Treasure Valley would make more sense there.
I'm assuming St. Luke's, St. Al's. Do you want West Valley in there, or you just, those two are good? Okay. I think we said good with that. Here's the motion. All right, motion is ordered.
Madam Chair, I would move that masks continue to be required in the classrooms. When positive cases are identified within the school, the district will provide notification to all students and parents from the classrooms that the positive case attended. The district will revisit the mask requirement when any one of the following triggers are met. First trigger, crisis standards of care removed from St. Luke's and St. Al's hospitals within the Treasure Valley. Trigger 2, vaccine availability for students aged 5 to 11, both doses in the required inoculation period. Trigger 3, the moderate community spread within Ada County.
Thank you. Is there a second?
I'm in second.
Thank you. Any discussion? So you're going to kick me under the table for this, but I think we probably need, and we can just do it in a second motion, maybe, but I think we also need to say that we're going to remove contact tracing while masks are required. Because we don't actually say that anywhere, and if that was your intent. Oh, so maybe this is my question to school operations, but we notify students and parents from the classrooms when a positive case attends today. I got notification, so I don't know how. We don't notify any parents when a positive case is in a classroom today?
Right.
If you've been exposed in the classroom, right? So half of the classroom could get notification today and half couldn't.
Right.
And so if you read this language, the way it's written right now, it just says they'll get notified. It doesn't say we're removing contact tracing at all. So I just think it, and that can be a second motion that just says when masks are required, we're going to remove contact tracing. It doesn't have to be in this one, but that's up to you guys. I'm just looking for clarity, so.
Madam Chair, I'll withdraw my motion.
Sorry, thank you.
Maybe when positive cases are identified within the school.
How about you just
let me
put it
write
at
it.
the
Hold on.
front? We could just say contact tracing will be removed in this status and when positive cases are identified in the school. Oh, here, we could actually have a recommendation.
Thank you.
Mm-hmm. Thank you. Oh. You already have the doctorate. All right. Poor Troy. You have like 50 backseat drivers right now. You're totally fine.
Thanks, Troy.
Yeah. Trustee Ozuna?
Madam Chair, are we ready for a motion?
I think so.
Awesome. I would move that masks continue to be required in the classrooms. When positive cases are identified within the school, in lieu of contact tracing, the district will provide notification to all students and parents from the classrooms that the positive case attended. The district will revisit the mask requirement when any one of the following triggers are met. Crisis standards of care removed from St. Luke's and St. Al's hospitals within the Treasure Valley. Vaccine availability for students aged 5 through 11, both doses in the required inoculation period, or moderate community spread within Ada County.
Thank you. Is there a second?
Second.
It's been moved and seconded. The motion on the screen is before the board. I just want to, for the record, say that this was a lot simpler than Trustee Kofeld's motion last time we did it after 10 o'clock. So.
It was a little deja vu.
And he wasn't going to do that again. He was like, I'm out this time.
I sat quiet.
So, is there any discussion? All right. Seeing the discussion, we'll call for a vote. All those in favor, please say aye.
Aye.
Chair votes aye. All those opposed?
Nay.
Motion carries 4-1. Thank you. All right. Trustee Kloppenstein, you're up.
So moved.
Yeah. Motion, it's been moved and seconded that the board adjourn. All those in favor, please say aye.
Aye.
Motion carries 5-0. Thank you.